Welcome to Section 5 in Neurology. In this section, we will be discussing the cerebellum. So let's get started. So first, we're going to go over the cerebellar anatomy really quick. And the main thing you need to know is that there are hemispheres, there's the vermis, and the flocculonodular lobes. And the hemispheres are primarily responsible for the limbs, so the lateral corticospinal tract. And if damaged, it can cause limb ataxia, intention tremor, dysmetria, and dysdiadochokinesia. And we'll explain what these look like. Now, the vermis can be called the spinocerebellum, and this interacts with the axial muscles, so the anterior corticospinal tract. If you damage this, you can get truncal ataxia, or ataxia while walking, gait ataxia. Now, the flocculonodular lobes can be called the vestibular cerebellum, and it's involved with eye movements. And if damaged, you can get truncal ataxia, just like with a vermis damage, and you can also get nystagmus. So here's figure 8.26 from your text. On the right is a mid-sagittal view of the cerebellum. Now, the right side of the image is anterior, and the left side of the image is posterior. If we took a coronal cut of this right image, we would get the image on the left. Now, the top of the left image is superior, and the bottom is inferior. So looking at the left image, we can see that the middle portion is the vermis. And as mentioned in the previous slide, if this is lesioned, the patient will demonstrate truncal ataxia or gait ataxia. So the patient will appear uncoordinated while walking. On the outside, we have the hemispheres, which you can see labeled on both images. Now, if you lesion the lateral hemispheres, then you will get ipsilateral limb ataxia. Symptoms of limb ataxia include dysmetria, dysdiadochokinesia, and intention tremor. And we will discuss these symptoms and what they look like more on the next slide. Now, on the bottom, we can see the flocculonodular lobe, and this is involved in eye movements. So if this is lesioned, the patient will demonstrate nystagmus, or repetitive, uncontrolled eye movements. So this is a general overview of the cerebellum. So if you remember what has been described here, you will correctly answer almost all of the cerebellum questions you will get for step 1. There is a little bit more information you need to know, however, so let's quickly go over that. So this is a review of the cerebellar anatomy. So now let's review what these lesions will look like. So if you damage the hemisphere, you get hemisphere lesions. Once again, you'll get limb ataxia. Recall that you'll get intention tremor, dysmetria, or dysdiadochokinesia. Now, intention tremor is trembling when making a movement. And remember, it's going to be on the ipsilateral side. So if the patient damages the right cerebellar hemisphere, then the right arm or right leg will demonstrate trembling when that patient is trying to move those limbs. Now, dysmetria is undershooting or overshooting with a finger. And this can be tested when a clinician asks a patient to touch his or her finger with the patient's own finger. And sometimes they'll overshoot it or undershoot it, and this is called dysmetria. Now, dysdiadochokinesia means that the patient cannot perform rapid alternating movements. So in clinic, patients can be asked to flip their hands on their lap over and over and over again so that their palms face up and then down, up and then down, and do it really quickly. And if they have a hemisphere lesion, then they could demonstrate dysdiadochokinesia and will be unable to do it with that limb. So now talking about vermis lesions, so in the center, or the midline of the cerebellum. If you damage this, you'll get truncal ataxia, so that's a lack of coordination while walking. This can be gait ataxia as well. This is a general overview of truncal ataxia. There can be other symptoms, for example, while the patient's sitting, and they have a hard time maintaining posture because of truncal ataxia. But for the most part, you're going to see it with gait. They're going to have trouble walking. And flocculonodular lesions will cause truncal ataxia, just like we mentioned with the vermis lesions, and will result in gait ataxia. But it will also result in nystagmus, which is those repetitive, uncontrolled eye movements. So now let's talk about the layers and the fibers of the cerebellum. We have the white matter in the center, and then there's the molecular layer, the granular layer, and the Purkinje layer. So let's draw this out. So this is figure 8.27 from your text. In the middle is the white matter, which we have labeled. So to put this simply, a signal will travel into the cerebellum through the white matter. If the cerebellum is to send information out in order to modulate movement, then the Purkinje cells, this layer here, will be stimulated. So you can see that right there. And these Purkinje neurons, if they are to send a signal out of the cerebellum, will send their signal to the deep nuclei of the cerebellum. Before we talk about these deep nuclei, just remember that the Purkinje neurons are the only output of the cerebellar cortex. Now granted, this is a little simplistic, and the cerebellum is a little bit more complex than that. However, for step 1 purposes, just think that the output from the cerebellum is through these Purkinje neurons. So now let's talk about these deep cerebellar nuclei. There's the dentate nucleus, which is the most lateral one, and there's the embelliform, globose, and fastigial. Now each nuclei corresponds to a specific location of the cerebellum, and all receive an inhibitory input from the Purkinje neurons, which, as we recall, is the output of the cerebellar cortex. It's best to imagine that by default, these deep nuclei are sending off signals. When the Purkinje neurons release GABA, the deep nuclei will be inhibited. This allows the cerebellum to modulate movement as necessary. And then these nuclei, once stimulated, or rather inhibited by GABA, they will all send axons out of the cerebellum via the peduncles. Now to remember these nuclei, some people like to say, don't eat greasy foods. So dentate, embelliform, globose, and fastigial, from lateral to medial. Personally, I like degrees Fahrenheit, just easier for me to remember. So remember, lateral and fastigial is the most medial. This is figure 8.28 from your text, which shows a transverse section of the cerebellum and the deep nuclei. Now from the most lateral, we have the dentate. So this is the don't, and then we have the embelliform nucleus. And on the right half, we can see it right here. So E for embelliform, and then we have the globose, which you can see right here. G for globose, and then we have the fastigial nucleus. So don't eat greasy foods, or simply degrees Fahrenheit. So you don't need to be able to identify all 4 of these nuclei. In fact, the only one that you should really be able to identify grossly is the dentate nucleus. As you can see, it's very large. The takeaway is that the Purkinje neurons will send axons to these nuclei and release GABA. And this is an inhibitory neurotransmitter, and it will inhibit these nuclei. And these nuclei will then send out axons through the peduncles, which we will talk about next. So if we put figures 8.27 and 8.28 side by side, we can see that a signal from the Purkinje cell will then go to the deep nuclei, where GABA is released, and then the nuclei will then send a signal out the peduncles. So now let's talk about these signals that exit the peduncles. Now, starting with the superior peduncle, this will send proprioceptive information out to the contralateral VL of the thalamus, VL standing for ventral lateral nucleus. Now, after reaching this point, the VL will then send projections to the motor cortex. Now, the middle peduncle will send intention information in from the contralateral cerebral motor cortex. In other words, the cerebral motor cortex will send information to the cerebellum about what movements are about to take place in the body, so intention. Finally, the inferior peduncle will receive proprioceptive information in from the spinal cord. So here is figure 8.29 from your text. This shows the 3 pathways for the cerebellum that you will need to be familiar with. So let's start with this blue line. Recall from section 2 that the motor cortex, via the corticospinal tract, will send fibers down and initiate movement. Now, while the motor cortex innervates the muscles, it will also send motor information to the cerebellum, as if to tell the cerebellum what the motor cortex is intending to do. This can be called intention information. So we can erase this corticospinal tract line, and we'll just focus on this cerebellar pathway. So the motor cortex will send intention information to the cerebellum, and this is via the corticopontocerebellar tract. Now, meanwhile, the muscles are moving, because recall that the motor cortex actually innervated the muscles. So there's going to be proprioceptive information that will be sent back to the cerebellum. This is what you can see with this green line. This is proprioceptive information, which, as you can see in the key on the right, this is the spinocerebellar tract. Now, recall that the dorsal column is what carries the proprioceptive information. So the dorsal column carries the spinocerebellar tract. Now, this information will tell the cerebellum where the body is and how the movement is going. You may recall from section 2, where we discussed the dorsal column medial lemniscus pathway, that the proprioceptive information will decussate at the medulla. So as the proprioceptive information is carried up through the dorsal column, it will decussate at the medulla, and it will cross the midline. This is not the case with the spinocerebellar tract, so we'll erase that. For this tract, think of it as staying ipsilateral and never crossing the midline. As you can see clearly here, it does not cross the midline. Technically, there are 2 parts of the spinocerebellar pathway, and one does cross the midline, like this, but it crosses back, so it eventually ends up on the ipsilateral side. So the point is that you can always think of the spinocerebellar tract as staying ipsilateral. So to summarize, the motor cortex innervated a muscle causing movement. The motor cortex also told the cerebellum the intention, and then the cerebellum received information via the spinocerebellar tract and carried the proprioceptive information to see how the movement is actually going. So now the cerebellum has the information about what should be happening and what is actually happening. This brings us to the red line, the cerebellothalamic tract. Now, this is where the cerebellum will send information to the ventral lateral nucleus of the thalamus, which will then go to the motor cortex. Now, the motor cortex can then fine-tune its movements, leading to even greater precision because of the information that the cerebellum provided. Now, a way I like to remember the function of each one of these tracts is to look at their names. The spinocerebellar tract goes from the spine to the cerebellum, in that order. The corticopontocerebellar goes from the motor cortex to the pons, and then to the cerebellum, in that order. Now, don't worry about the pons in this tract. It's enough to know that this tract goes through the pons before reaching the cerebellum. Now, the cerebellothalamic tract goes from the cerebellum to the thalamus, in that order. And of course, if it goes to the VL of the thalamus, the VL will then innervate the motor cortex. Now, why is this relevant? Well, first, know that this is the left side over here, because we are looking at the dorsal aspect of the brainstem. And if you damage this left side of the cerebellum, then the right motor cortex, which is up here, which is trying to innervate this left side of the body, will be all messed up. So the patient will develop ipsilateral or left-sided limb ataxia. And ipsilateral ataxia includes intention tremor, dysdiadochokinesia, or dysmetria, which we discussed earlier. So just remember that cerebellar damage will cause ipsilateral signs. Now, one thing that you also need to know is the peduncles that are used. Now, the spinocerebellar tract uses the inferior peduncle, which we have labeled on the right side. We'll fill that in with green right here. The corticopontocerebellar tract will use the middle cerebellar peduncle, which you can see, this large one. We'll fill that in with blue. And finally, the cerebellothalamic tract will use the superior cerebellar peduncle to send information up to the motor cortex. So just as a review, the incoming tracts, the spinocerebellar and the corticopontocerebellar tracts, will enter through the white matter, and then the Purkinje neuron will be stimulated, and it will send fibers to the deep nuclei, and these deep nuclei will then be stimulated to send their information through the cerebellothalamic tract, through the superior cerebellar peduncle. Now, the cerebellum can become much more complex than this if you want it to be complex. However, for step 1, these are pretty much all the facts you need to know. Now let's do some questions to apply this knowledge. During a neurologic exam, a patient is unable to touch the clinician's finger with his own right finger. However, he is able to touch the clinician's finger with his own left finger. A CT scan reveals a tumor in the cerebellum. Where in the cerebellum would you expect to find the tumor? So this patient is unable to touch the clinician's finger with his own finger. This is a classic representation of dysmetria, which we discussed earlier in this lecture. The patient demonstrates dysmetria on the right side, but not the left side. Due to this clinical symptom, dysmetria, we are thinking of a cerebellar lesion. The CT scan shows a tumor in the cerebellum, so where do we expect this tumor to be? Well, dysmetria is a sign of a hemisphere lesion, so we suspect the right cerebellar hemisphere. Now, this may seem pretty straightforward and simple. The patient has right-sided cerebellar symptoms, so we suspect the right cerebellar hemisphere is damaged. But this is exactly how you'll be tested on step 1. The cerebellum is very straightforward. Don't overcomplicate it. Now, let's do one more question. Now, a patient seems to have uncoordinated movements while walking. If cerebellar damage is the cause of this presentation, where is the damage likely to be? Now, this presentation is describing gait ataxia or truncal ataxia. So where in the cerebellum is there likely to be damage? Well, gait or truncal ataxia makes us think that it could be the vermis or the floccular nodular lobe. These both can result in gait or truncal ataxia. Now, without more information, you can't really know which of these two it is. However, if I told you that on clinical exam the patient has no nystagmus, you would then no longer suspect the floccular nodular lobe. Instead, you would just think it's the vermis. So now let's review the peduncles. The superior peduncle will send proprioceptive information out to the contralateral VL of the thalamus. And from that VL, it will send information to the motor cortex. And this is called the cerebellothalamic tract, because it goes from the cerebellum to the thalamus, and then finally the motor cortex. Next, we have the middle peduncle, which starts in the motor cortex of the cerebrum and sends intention information in from the contralateral cerebral motor cortex. And this is called the corticopontocerebellar tract because it goes from the cortex through the pons and then ends up in the cerebellum. Lastly, we have the inferior peduncle, and this will take proprioceptive information in from the spinal cord. So this is called the spinocerebellar tract. So spine and cerebellum. So now let's quickly talk about the vestibulocerebellar tract. And as it sounds, you got the vestibulo, so vestibular nuclei are involved. Then you have the floccular-nodular lobe, which is a part of the cerebellum. So what happens is it goes from the vestibular nuclei to the floccular-nodular lobe, and then it goes back to the vestibular nuclei. And then from that point, it goes to the cranial nerve 6, which is the abducens nerve. Now remember that the abducens nerve will innervate the lateral rectus muscle of the eye. And this whole pathway going from the vestibular nuclei to the floccular-nodular lobe, and then back to the vestibular nuclei, and then to the cranial nerve 6, and then finally the lateral rectus muscle, it all remains ipsilateral. It's all ipsilateral, which means that cerebellum is really, really simple. Just remember ipsilateral. Now, if you damage the vestibulocerebellar tract, you're going to get truncal ataxia, which we discussed previously, and you also get nystagmus due to this lateral rectus muscle stimulation. Here is figure 8.30 from your text, and it shows the relevance of the floccular-nodular lobe of the cerebellum, which is right there. Now, as you can see, the floccular-nodular lobe will send signals to the vestibular nuclei, which you can see with these red fibers. The vestibular nuclei will then send signals back to the floccular-nodular lobe, which we can see with this blue line. The point is that the cerebellum can interact with the vestibular nuclei, which then stimulate the cranial nerve 6, which then stimulates the lateral rectus muscle. So if you lesion the floccular-nodular lobe, then this pathway will get disturbed, and then there will be nystagmus of the eye, in this case, the right eye. Also keep in mind that the floccular-nodular lobe, much like the vermis, can cause truncal or gait ataxia, which we discussed earlier in this lecture. So if a patient presents with gait ataxia, and you're trying to distinguish between a lesion in the vermis versus the floccular-nodular lobe, then you can just look at the eyes to see if the patient demonstrates nystagmus. If so, you're more inclined to think that the floccular-nodular lobe has been lesioned and not the vermis. Now let's briefly talk about how to dominate cerebellum questions on step 1. So first, remember that if the hemisphere is lesioned, this will cause limb ataxia. There's 3 things you need to remember about limb ataxia. That's intention tremor, dysmetria, and dysdiadochokinesia. And always remember that the symptoms are ipsilateral. If you damage the right hemisphere of the cerebellum, you'll get right limb ataxia. Also remember that the vermis causes gait and truncal ataxia if lesioned. And then recall that the floccular-nodular lobes, when lesioned, will cause gait or truncal ataxia and nystagmus. Nystagmus being how you can distinguish clinically from a vermis lesion. And that concludes this section. Welcome to section 6 in neurology. In this section, we will be discussing the basal ganglia and the dopaminergic pathways. So let's get started. So the basal ganglia is responsible for smooth, voluntary movements. It's composed of the striatum, which is composed of the caudate and putamen, and the lentiform, which is composed of the putamen and globus pallidus. It also has the substantia nigra, pars compacta, and the C for compacta. It also has the subthalamic nucleus, or STN for short. Now the basal ganglia contains the direct pathway, which increases movement, as well as the indirect pathway, which decreases movement. So now let's show some anatomy of these locations. Here is a sagittal view of the brain. This is actually figure 8.4, which was discussed in section 1 of this chapter. What I would like to have you focus on now is the basal ganglia. As you can see, the caudate is here. It actually extends back and then curves forward again. And then we have the putamen, which, as this line indicates, is right here. And just medial to that is the thalamus, as you can see here. Now the globus pallidus is actually medial to the putamen, and you can't really visualize it here. But if we were to take a coronal section of the brain and cut it through this portion, we would see figure 8.5. Figure 8.5 was also discussed in section 1 of this chapter. So now we can see that the caudate nucleus is located here, and that the thalamus is located here. And then of course we have the putamen, right in this region, and then the globus pallidus externus, and then the globus pallidus internus. Now let's show a slightly more posterior coronal cut of the brain on a new slide. Since we are more posterior than in figure 8.5, shown in the previous slide, we can see the brainstem right here, and the substantia nigra in the midbrain. As we will discuss later in this lecture, the substantia nigra plays an important role in the basal ganglia. As discussed in section 3 of this chapter, the red nucleus is also in the midbrain, right here and right here. That is the red nucleus. And we will discuss the relevance of knowing that the substantia nigra and the red nucleus are located in the midbrain once we get later in this lecture and discuss the dopaminergic pathways. So now that we have our landmarks, let's discuss the direct and indirect pathways of the basal ganglia. So on the left, we've demonstrated the direct pathway, and on the right, we've demonstrated the indirect pathway. It's important to recognize that both the indirect and direct pathways are on both sides of the brain, but for simplicity in this lecture, we will illustrate the indirect and direct pathways separately on separate parts of the brain. So now let's first discuss the direct pathway. So the direct pathway is the excitatory pathway, which means it increases movement. And the pathway starts in the motor cortex, which then stimulates the striatum, specifically the caudate and the putamen, at which point the neurotransmitter GABA is released, and then we'll see inhibition of the globus pallidus internus, which causes decreased inhibition of the thalamus, specifically acting on the ventrolateral nucleus. Decreased inhibition causes increased excitement of the motor cortex, which leads to increased movement. So let's draw this out. So we start up here in the motor cortex, which then sends signals to the striatum. So the caudate right here and the putamen right there. The neurotransmitter released into the striatum is glutamate. Now this is an excitatory neurotransmitter, which is why these arrows are green, as in go. So now the putamen is activated and it releases GABA, which acts on the globus pallidus internus, which as you can see right here. Now GABA is inhibitory, hence the red arrow. Now, the globus pallidus internus normally inhibits the thalamus by releasing GABA, specifically at the ventrolateral nucleus. We'll just write VL. The nuclei of the thalamus, which include the VL, are important, and they are discussed in the thalamus lecture of this chapter. So what's important to recognize is that because of the activation of the putamen, the globus pallidus internus is inhibited by GABA, which means that its effect is inhibited, which means there is increased excitement from the thalamus going to the motor cortex. So this is the gist of the direct pathway, or excitatory pathway. The putamen has inhibited the inhibitor, which is the globus pallidus internus. So now let's talk about the indirect or inhibitory pathway. Now, the indirect or inhibitory pathway decreases movement. So a signal starts in the motor cortex and then stimulates the striatum, the caudate, and the putamen, and then GABA is released, which causes increased inhibition of the globus pallidus externus, which then causes decreased inhibition of the subthalamic nucleus, which causes increased stimulation of the globus pallidus internus. And as we recall from the direct pathway, the globus pallidus internus inhibits the thalamus, so there's decreased stimulation of the thalamus, again acting on the ventrolateral nucleus within the thalamus. Greater inhibition of the thalamus means that there is decreased excitement of the motor cortex, which ultimately leads to decreased movement. So let's draw this out. So now we're focusing on the other half of figure 8.1 from your text. So motor stimulation comes to the striatum, as we discussed with the direct pathway, goes to the caudate, and it also goes to the putamen. And the putamen is stimulated to release GABA into the globus pallidus externus, which is clearly labeled on this left half, so I'll start it right there. So GABA is released, and the globus pallidus externus is inhibited. Normally, the globus pallidus externus inhibits the subthalamic nucleus, right here, so it would release GABA. However, with the stimulation of the putamen, which causes the inhibition of the globus pallidus externus, so the activity of the subthalamic nucleus is increased. And as you can see, there's a green arrow going from the subthalamic nucleus to the globus pallidus internus. And as we recall from the direct pathway, the globus pallidus internus actually inhibits the thalamus. So the point is that in the indirect pathway, the motor cortex has stimulated the putamen, which then inhibits the inhibitor of the globus pallidus internus. So the globus pallidus internus can be activated, which leads to inhibition of the thalamus, which actually means there is decreased stimulation of the motor cortex, and therefore decreased movement. So now let's talk about how to rock the basal ganglia questions on step 1. So the first thing you need to know is know the anatomical locations of each component of the basal ganglia, so namely the caudate and putamen, and also know the globus pallidus and the thalamus. On the left is figure 8.7 from your text, showing an axial cut of the brain. This was discussed in section 1 of this chapter. On the right is figure 8.5 from your text, showing a coronal cut, which we showed previously in this lecture. Now be sure to identify every element of the basal ganglia in each of these images. So on the left, we have the caudate nucleus right here. Then we have the putamen right here. We have the globus pallidus externus and globus pallidus internus. And on the right, we have the caudate nucleus right here. And we have the putamen right here. And we have the globus pallidus externus and internus. Now with a sagittal cut of the brain, looking at figure 8.4 from your text, which was discussed in section 1 of this chapter, we can identify, once again, the caudate right here, which curves around, the putamen is right here, and then just medial to that is the globus pallidus, which would be in here, which is not easily visible from this perspective. So now let's talk about the other portion of rocking your basal ganglia questions, which is knowing the lesions. The first thing you need to know is that damage to the subthalamic nucleus leads to hemibolism, or hemibolismus. Next, know that damage to the striatum, or the caudate and putamen, leads to Huntington disease. Also, it's really important to know that unilateral lesions cause contralateral signs, and we'll explain what we mean by all of this. Here's the full image of figure 8.31 from your text, and notice that if you damage the subthalamic nucleus, you will cause dysfunction of the indirect pathway. So you will see signs of lack of inhibition, because remember that the indirect pathway decreases motor cortex stimulation, which decreases movement. So if you decrease the indirect pathway, you will actually increase motor cortex stimulation and increase movement, which leads to wild flailing movements known as hemibolismus. So remember, whenever you get damage to the subthalamic nucleus, you're going to get hemibolismus, which is the wild flailing movements. The next point is that unilateral lesions will cause contralateral signs. So on this side, we have the patient's left, and on this side, we have the patient's right. So if we damage any part of the right side of the basal ganglia, we would only get signs on the left side of the body. The reason is because the basal ganglia is responsible for modulating the motor cortex. And as you recall from section 2 on the spinal tracts, specifically regarding the corticospinal system, the motor cortex will send fibers through the internal capsule, which then decussate at the medulla. So damage to any part of the right basal ganglia will be manifest with left-sided symptoms. So the last point to make about the basal ganglia is regarding Huntington's disease. I will just write HD. Huntington's disease is a hereditary disease which damages the striatum, so both the caudate and the putamen. So this will damage both the direct and indirect pathways. After all, both the caudate and putamen are involved in both the direct and indirect pathways, as seen on this image. Recall that the indirect pathway is mainly inhibitory, while the direct pathway is mainly excitatory. So in Huntington's disease, we are affecting both the excitatory component of the basal ganglia as well as the inhibitory component of the basal ganglia. So damage to the indirect pathway will cause loss of inhibition, so we'll have decreased inhibition, which leads to the cortex being overstimulated, which results in the jerky movements known as chorea in Huntington's disease. Conversely, where the direct pathway is mainly excitatory, and we actually have decreased excitement, patients with Huntington's disease will actually demonstrate that decreased slow movement. So the slow movement and these jerky chorea movements are both known to be in Huntington's disease. So let's do a question to apply this. So let's say a 27-year-old female patient presents with rapid involuntary movements in both arms. Now she was adopted and is unable to provide an adequate family history. From the image below, what region of the brain is likely damaged? So here we're looking at the basal ganglia. So with these symptoms, and given the fact that we know that because of the question stem, our patient has something wrong with the basal ganglia, we should be thinking of one of two things. First, Huntington's disease, and second, hemibolismus. So the rapid involuntary movements should make you think of the chorea in Huntington's disease. So since we are thinking about Huntington's disease, we would think that the striatum is damaged, so the caudate and putamen on both sides. Now, the reason we're not thinking it's hemibolismus is because if this patient had hemibolism, we would see more of a wild flailing on one side of the body, which is really not what we're seeing here. However, if we were thinking this patient had hemibolismus, we'd be thinking of damage to the subthalamic nucleus. And it would have to be in both sides because this patient is demonstrating symptoms in both arms. But again, that's not what this patient's demonstrating, so we're thinking it's Huntington's disease. So now let's talk about the dopaminergic pathways. Now the dopaminergic pathways project axons to various locations in the brain to deliver dopamine. Now there are four major pathways: the nigrostriatal, the mesolimbic, the mesocortical, and finally the tuberoinfundibular. Now this is figure 8.32 from your text, which shows all four dopaminergic pathways. We are going to go through each pathway on this image one by one, so don't worry about memorizing it now. For now, just focus on the midbrain. If we took an axial cut of the midbrain like this, we would see figure 8.16, which was discussed in section 3 of this chapter. Notice how we can see the ventral tegmental area and the substantia nigra. The ventral tegmental area houses the cell bodies for the mesolimbic and mesocortical pathways, and the substantia nigra houses the cell bodies for the nigrostriatal pathway. If you remember these two areas, the ventral tegmental area and the substantia nigra, it will make understanding the dopaminergic pathways so much easier. So let's start with the nigrostriatal pathway. So the substantia nigra is divided into two parts. The part we're concerned about is the pars compacta, hence the C in this SNC. Now this releases dopamine, which travels to the striatum, so the caudate and putamen, hence the term nigro as in substantia nigra and striatal as in striatum. Now dopamine stimulates the D1 and D2 receptors found in both the putamen and the caudate. And when the D1 receptor is stimulated, it causes the excitatory pathway to be stimulated, which leads to increased movement. Now the D2 receptor stimulation causes the inhibitory pathway to be inhibited. We've inhibited the inhibitory pathway, which also leads to increased movement. In other words, the nigrostriatal pathway stimulates movement via the basal ganglia. So now let's look at our image of 8.32. So here we have the substantia nigra in red. We're going to follow the nigrostriatal pathway, which starts here in the midbrain. Recall this is the midbrain area, and it goes all the way up until it reaches the striatum in this area. Now let's look back at figure 8.31 to apply this to the basal ganglia. So the nigrostriatal pathway can stimulate the D1 receptors to stimulate the excitatory pathway. So there are D1 receptors in the caudate and the putamen. So the substantia nigra on both sides will stimulate the direct pathway by stimulating the D1 receptors, which causes increased activity of the direct pathway. At the same time, dopamine stimulates the D2 receptors, which are also in the caudate and putamen. Now when the substantia nigra stimulates the D2 receptor in the inhibitory pathway, it will cause decreased inhibition. So in other words, we will have decreased activity of the indirect pathway. So ultimately, the nigrostriatal pathway leads to increased movement. So now let's do a question to apply this. Now what symptoms would you expect with damage to the substantia nigra? Okay, with damage to the substantia nigra, there would be loss of stimulation of the D1 and D2 receptors. Therefore, there will be less excitement of the basal ganglia and the motor cortex. So the patient will present with decreased movement, or specifically, slow movement. So what we are talking about here with damage to the substantia nigra is Parkinson's disease. So we can expect all of the same symptoms of Parkinson's disease, including poor posture and tremors, which we can attribute to lack of stimulation of the D1 and D2 receptors in the striatum. So now let's talk about the mesolimbic pathway. In the mesolimbic pathway, the ventral tegmental area, which is in the midbrain, releases dopamine. The dopamine then travels to the nucleus accumbens, which is a part of the limbic system. And it also travels to other structures within the limbic system. So it can be easy to remember what the mesolimbic pathway is when we remember that the midbrain is also called the mesencephalon, as in meso in mesolimbic. And since we're dealing with the limbic system, we get the term limbic in mesolimbic pathway. Now the nucleus accumbens is the reward center of the brain, and it's associated with drugs, addictions, food, sex, and other things like that. When you have hyperactivity of the nucleus accumbens, you get the positive symptoms of schizophrenia, which include delusions and hallucinations. Now the mesocortical pathway is very similar in that we can remember that it begins in the ventral tegmental area, which is in the midbrain, which is also called the mesencephalon, as in meso for mesocortical pathway. And just like in the mesolimbic pathway, the mesocortical pathway has dopamine, which travels to the prefrontal cortex, hence the term cortical in mesocortical pathway. Now the prefrontal cortex is responsible for motivation, emotion, and executive functions. And when you have decreased activity or hypoactivity of the mesocortical pathway, you get the negative symptoms associated with schizophrenia, which include flat affect, anhedonia, avolition, and other things. So now the last pathway is the tuberoinfundibular pathway. In this pathway, the hypothalamus releases dopamine, which travels to the anterior pituitary, which then inhibits the release of prolactin. So if you have dysfunction of this pathway, you're going to have decreased inhibition, which causes increased serum prolactin. And when you have hyperprolactinemia, you will get decreased libido, galactorrhea, and other things. So now looking again at figure 8.32, we have the tuberoinfundibular pathway going from the hypothalamus, right, in this region, to the anterior pituitary. And as we mentioned in the previous slide, when we damage the tuberoinfundibular pathway, we get decreased dopamine, which causes decreased inhibition of prolactin secretion, which of course leads to hyperprolactinemia. For more information about prolactin secretion, please watch the endocrine chapter. So now let's review all of the dopaminergic pathways together. Recall that they all project axons to various locations in the brain to deliver dopamine. And there are 4 major pathways. The nigrostriatal, which goes from the substantia nigra to the striatum. And if you have destruction of this, you get Parkinson's disease. And the mesolimbic pathway goes from the mesencephalon or midbrain, specifically the ventral tegmental area, to the limbic system. And when you have hyperactivity of this system, you get the positive symptoms associated with schizophrenia. And the mesocortical goes from the ventral tegmental area to the prefrontal cortex. When this is hypoactive, you get the negative symptoms associated with schizophrenia. And finally, as we just reviewed in the previous slide, the tuberoinfundibular pathway is responsible for inhibiting the release of prolactin. So when it's hypoactive, you will get hyperprolactinemia. Now, if you can remember these 4 pathways, their locations, and what happens if they are dysfunctional, as written here, you will do quite well on any question you get regarding these pathways. So let's just do one last question to review. What pathway is affected, causing a flat affect in a schizophrenic patient? So to answer this question, you just need to think about what dopaminergic pathway is responsible for emotion and motivation. Now that would be the prefrontal cortex. And that means that we're dealing with the mesocortical pathway. As you recall, the prefrontal cortex is responsible for emotion and motivation. If you have dysfunction of this pathway, you're going to have decreased emotion and motivation, which gives you those negative symptoms associated with schizophrenia. As a side note, recall that when dealing with the mesolimbic pathway, here in green, when you get this hyperactive, you're actually going to get increased activity of the limbic system, including the nucleus accumbens, which causes those positive symptoms associated with schizophrenia. When you have a problem with the nigrostriatal pathway, or damage to the substantia nigra, you're going to get Parkinson's-like symptoms, or Parkinson's disease. And when you think tuberoinfundibular problem, think hyperprolactinemia. And that concludes this section. Welcome to section 7 in neurology. In this section, we will be discussing audiology and balance through the vestibular system. So let's get started. So let's first talk about auditory transduction. Now, it's not going to help you to just read this out to you. However, we want to provide you with a thorough textual version of this pathway so you can refer back to in your text. But for now, let's just draw it out on a new slide. This is figure 8.33 from your text, showing the first portion of auditory transduction. So as you can see, sound waves will enter the auditory canal in the outer ear right here and cause the tympanic membrane to vibrate. The auditory ossicles, the malleus, incus, and stapes, will then transfer the vibration to the oval window. So now we're going to focus just on the cochlea. So right in here, we're just focusing on the inner ear. We've passed the outer ear and the middle ear. If we take a cross section of just one canal within the cochlea, like this, we would get figure 8.34 from your text. So now we are within the cochlea. When you see this figure, picture any point along the cochlear spiral. So movement of the oval window will cause the perilymph within the cochlea to shift. Perilymph is within the scala vestibuli and the scala tympani. So the perilymph is shifting because of the vibrations through the cochlear window. So we will say the perilymph is shifting up. And this shifting within the perilymph is actually transferred to the organ of Corti, and it causes the basilar membrane to shift as well. The basilar membrane houses the hair cells, which can then press up against the tectorial membrane. So you can see these little hair fibers, the cilia, pressing up against the tectorial membrane. And so if this basilar membrane is shifting, then these hair cells are going to bend against the tectorial membrane. The bending of the hair cells causes cranial nerve 8 to fire, specifically the auditory part of it. So this is a very significant point. This is where sound waves actually become electrical stimulation of an actual nerve. So it is at this point that cranial nerve 8 is stimulated. Now this is actually how a cochlear implant works. They cause electrical stimulation of the auditory nerve because the structures within the external ear and the middle ear are dysfunctional. So the cochlear implant will just skip these 2 portions of the ear that are responsible for conducting the sound waves and vibrations and then just directly stimulate the cochlea, the inner ear. In other words, the sensory portion of the ear. So now we know that cranial nerve 8 is stimulated. We can pull up a new slide to see what happens next. On the right is figure 8.35 from your text, and it shows a posterior view of the brainstem. On the left is figure 8.21 showing a cross-section of the medulla, which was discussed in section 3 of this chapter. So the cranial nerve 8 fibers will travel into the pons to the nucleus. Then the nucleus will then send up fibers through the lateral lemniscus. Now, knowing where the lateral lemniscus is located on a cross-section is not going to be super helpful for step 1 purposes. What will be helpful is knowing that the fibers from the nucleus of cranial nerve 8 go to both the superior olivary nucleus on the ipsilateral and the contralateral side. The superior olivary nucleus, much like the inferior olivary nucleus, is located within the pons and the medulla, which you can see here. Just to clarify, the inferior olivary nucleus is a prominent feature of the medulla, making it very important to recognize when viewing a cross-section of the medulla. Now, on the other hand, the superior olivary nucleus, which actually receives stimulus from the auditory pathway we're discussing, is not very prominent, and therefore not important to identify on a cross-section. Now, fibers from this right cranial nerve 8 nucleus will then travel to the midbrain to the ipsilateral olivary colliculus, as we can see labeled here. And the cranial nerve 8 nucleus will also send fibers to the contralateral inferior colliculus. So the point is that signals from the right ear will travel to both sides of the brainstem, and the same goes for the left if we were to draw the pathway of cranial nerve 8 from the left ear. In other words, there's so much crossover within the brainstem. Therefore, if you damage the auditory pathway within the brainstem, for example with an ACA stroke, and just on the left side, you will get left-sided hearing loss and right-sided hearing loss. Whereas if you cause damage to just the cranial nerve, for example on this right side, you will only get right-sided hearing loss. So brainstem lesions on either side will cause bilateral hearing loss, but peripheral lesions, just damaging the cranial nerve, will cause unilateral hearing loss. So now let's talk about tonotopy and hearing loss. So to understand tonotopy, just know that sounds will produce vibrations of a certain frequency. Now each frequency is associated with a specific part along the cochlea. For example, the base of the cochlea is responsible for high frequency, and it's this high frequency that's lost in noise-induced hearing loss and presbycusis, or hearing loss of old age. Conversely, the locotrema, or the apex of the cochlea, is responsible for the low frequencies. So let's draw this out. So here on the left is figure 8.33, which we discussed earlier in this lecture. And as you can see, here's the cochlea, and if we straighten it out, we would get figure 8.36 on the right. So this wide portion of the cochlea, closest to the oval window, is actually the same part as over here, the base on this left image. Now on the right image, the apex right here corresponds to the apex right here. I just want to clarify so you can understand what we're looking at. So the premise of tonotopy is that high frequencies are here at the base, and the lower frequencies are here at the apex. Noise-induced hearing loss primarily affects the high frequencies first, damaging the cilia within the organ of Corti. And this makes sense because as sound enters the cochlea from the oval window, it will reach the base first before it reaches the apex. So it'll cause more damage to these high frequencies. So now let's do a question. Let's say there's a 70-year-old male factory worker who complains of hearing loss. What part of the cochlea is likely responsible for this loss, the base or the apex? Now what is being described here is noise-induced hearing loss. Recall that noise-induced hearing loss damages the base first, so in answer to our question, the base is likely responsible for the hearing loss. If we were to take the question a step further, we could ask if he has lost the ability to hear low frequencies or high frequencies. Recall from the previous slide that high frequencies are associated with the base of the cochlea. So damage to the cilia in the organ of Corti near the base would diminish his ability to hear at high frequencies. So we would suspect that he would have high frequency hearing loss. Now let's talk about the René test. This is a hearing test, and it's performed by taking a tuning fork and placing it near but not touching the ear. So the sound is just traveling through the air. The other portion of the test is where you take the tuning fork and place it on a bony area surrounding the ear. So sound is transferred through the skull. And what you get is an air to bone ratio. So when the tuning fork produced louder noise to the patient when it was not touching the bone, in other words, it was just in free air, then that patient has normal hearing. But this can also be the case if the patient has sensory neural hearing loss. In other words, damage to the inner ear. However, if the patient says that they were able to hear the sound better when the tuning fork was placed against their skull, then that would mean that the bone is louder than the air. And this implicates conductive hearing loss. In other words, the outer or middle ear is damaged. Now let's talk about the Weber test. So now the Weber test is taking that same tuning fork and placing it on the top of the skull. And this will localize the hearing loss to the affected ear. So that's very important. So if the patient says that they can hear in the right and the left ear equally, then that's normal. However, if they say that they can hear in the right ear better than the left, then you think, oh, that means they have left-sided hearing loss because they could not hear as well in that left side. And then just the opposite, if they say that they can hear in the left more than the right, that means they have right-sided hearing loss. So now let's do some examples. So a patient describes a muffling of sound in the right ear following a boating trip. Upon physical exam, there appears to be water lateral to the eardrum. What would be the results of the René hearing test? So what is being described here is a patient who has water lateral to the eardrum, so water within the external ear. So here's figure 8.33, which we discussed earlier. Now if water is in the external ear, as I'm drawing with this blue line, then we just need to determine what type of hearing loss this is. Is it conductive hearing loss, or is it sensory neural hearing loss? We'll recall from previously in our lecture that conductive hearing loss is anything that prevents sound from getting to the cochlea, so any blockage of the outer or middle ear. So we can clearly see that this patient has blockage of the outer ear, so this patient likely has conductive hearing loss. In the René test, if the patient has conductive hearing loss, the patient would say the sound is louder when the tuning fork is placed on the skull, because the tuning fork is able to transmit the sound through the skull to the cochlea, essentially bypassing the middle and outer ear. So the result of the René test would be that in this right ear, the bone conduction would be greater than the air conduction. So to review, if a patient has anything disrupting the outer or middle ear, then they will have conductive hearing loss. So the René test would produce results that would show that the bone conduction is louder than simply air conduction. Now let's talk about the vestibular system. Now the vestibular system is quite simple in that it maintains balance. And it's composed of 3 semicircular canals, as well as the utricle and the saccule. Now these semicircular canals are filled with endolymph, and there are hair cells with cilia within the endolymph. So vestibular transduction occurs when the cilia of the hair cells move against the endolymph. This will cause vestibular fibers to send signals to the vestibular nerve in the pons. So let's draw this out. So here's figure 8.33 from your text. So now we will focus on just the vestibular system right there. We mentioned that the vestibular system is composed of the 3 semicircular canals, as well as the utricle and the saccule. Now the utricle and saccule are in this region, but what you really need is a very basic understanding of just the semicircular canals. So here's figure 8.37, showing one semicircular canal. So each canal is filled with endolymph, represented with this blue. At the base of each canal is a cupula with hair cells and hair cell filaments, which you can see there. So when a person moves, the canal moves, and so the endolymph will shift, represented by these arrows. When the endolymph shifts like this, these hair cell filaments will be stimulated and will cause firing of the vestibular nerve. So what you need to know for step 1 is that when this system is messed up, for example, if you mess up the endolymph, then you're going to get vertigo. So an example is benign paroxysmal positional vertigo, which is caused by bone-like calcium flowing around in the endolymph. The endolymph can also be disturbed in Meniere's disease. Now, Meniere's disease is not fully understood, but it is postulated that it causes vertigo by having excess potassium within the endolymph. The point is that if you mess up the endolymph, the patient will get dizzy. More specifically, they will have vertigo. Now let's talk about the vestibular ocular reflex. Now the purpose of the vestibular ocular reflex is to maintain an image in the center of the retina. So for example, as the head turns to the left, the cortex, the frontal cortex, specifically the frontal eye field, will be stimulated. and this will induce the fast phase, which will also induce nystagmus. So the eyes will move left. Now, turning the head to the left will also cause firing of the left vestibular system, and this will initiate the vestibular ocular reflex, which will lead to the slow phase, or eyes moving in the opposite direction, which in this case is the right. So if the patient is unconscious, there will be no cortical input, which means the cortex will not be stimulated, so there will be no fast phase and no nystagmus. And if the brainstem is damaged, then the vestibular system will not function, so there will be no vestibular ocular reflex. So in other words, no slow phase. So let's draw this up. So here's figure 8.38 from your text showing the vestibular ocular reflex. So as you can see, the head is turning to the left. This turning of the head will stimulate the right frontal eye field, causing both eyes to quickly move to the left, which is this fast phase. Now this fast phase is the normal conjugate gaze that occurs when the right frontal eye fields cause the stimulation. We discussed this in the ophthalmology section using figure 8.45. Don't get wrapped up in that now. I just want you to recognize that the fast phase is initiated by the frontal cortex, which means that the patient must be conscious. So if the patient is unconscious, you will not see the fast phase, and that patient will not demonstrate nystagmus. Now, whenever you think of nystagmus in this particular process, associate it with the fast phase. Now, we will come back to the idea of nystagmus in a moment. As we just stated, as the head turns left, the right frontal cortex is stimulated, causing the eyes to quickly move in the same direction, so to the left. At the same time, as the head is turning left, the semicircular canals on the left will increase their firing, which we have labeled down here. So just remember that where the head turns, that same side will have a stimulated vestibular system. So in this case, the head turns left, so the semicircular canals on the left side will increase firing of the vestibular nerve. So that increased firing will cause the vestibular nerve to be activated, so the vestibular nucleus in the pons will be stimulated, particularly the left pons. It will then stimulate the right abducens nucleus, which will then stimulate the right lateral rectus muscle. Now the left vestibular nucleus will also stimulate the left ocular motor nucleus, which is in the midbrain, and this will then stimulate the left medial rectus muscle. So because of the increased firing of the semicircular canals in the left vestibular system, the vestibular ocular reflex will be stimulated, causing the eyes to shift to the right. This is the slow phase, as we've labeled here. Now, in order for the vestibular ocular reflex to function, or the slow phase to function, the patient requires an intact brainstem, because as you can see, we've used both the midbrain and the pons. This is useful to know because if a patient is unconscious or in a coma, you can tell if the brainstem is intact by using caloric stimulation, which is essentially squirting warm water into the ear. In this case, to keep things consistent, we will say that the warm water is being placed in the left ear, as we've labeled here. Now, this caloric stimulation of the left ear will increase the firing of the left vestibular system, which means the brainstem thinks that the head is turning to the left. Now, the patient is unconscious, so we don't expect the fast phase, and therefore we don't expect nystagmus. So we can ignore this in this unconscious patient, because it does not apply. However, we should still see the eyes move to the opposite side, or the right side in this instance. Now, if the vestibular ocular reflex is elicited, and the patient does in fact have eyes that move in the opposite direction, or to the right, then that means the brainstem is intact. However, if this slow phase, or the vestibular ocular reflex, is not elicited, then that indicates that there is brainstem damage. And this is a bad sign in a comatose patient. Now let's do a quick question to apply this knowledge. So let's say there's a female patient who is unconscious following a car wreck. The medics on site are able to elicit a normal pupillary light reflex, indicating proper brainstem function. If caloric stimulation with warm water was performed in the right ear, how would the patient's eyes respond? So we have an unconscious patient after a car wreck. Now the medic on site determines that the pupillary light reflex is functional, which as we stated means that the brainstem is functional. Now this is a good sign. Now what happens after the initiation of the caloric stimulation with warm water in the right ear? If we look at figure 8.38 again, we can walk through this. So if there's warm water in the right ear, then the brain is going to think that the head is turning to the right. And this means that the vestibular system, the vestibular ocular reflex, thinks that the patient is moving to the right, which means that the slow phase would occur to the left, meaning the eyes would shift to the left. And of course, they're unconscious, so the fast phase is not present. Now, would the patient get nystagmus? Nope. If the fast phase is not elicited, then there would be no nystagmus. So clinically, with this patient, with this caloric stimulation, the slow phase would be elicited, and the eyes would move to the left. So just to review, the vestibular ocular reflex maintains the image in the center of the retina so that as the patient's moving, they can continually see everything that they need to in a way that's not making them super dizzy. And to remember that when the head turns to the left, then the cortex will be stimulated and the eyes will move in the same direction. And this is the fast phase, and associate that with nystagmus. And also the head turning to the left would cause the slow phase to move the eyes to the right. And if a patient's unconscious, that means there's no cortical input, so there's no fast phase or nystagmus. And if there's brainstem damage, there's going to be no vestibular ocular reflex, so there will be no slow phase. And that concludes this section. Welcome to section 8 in neurology. In this section, we will be focusing on ophthalmology, including the visual pathway and its vascular supply, the pupillary light reflex, and the autonomic innervation of the eye, as well as internuclear ophthalmoplegia, or INO. So let's get started. So now let's discuss the visual pathway. So starting with the temporal hemiretina, which is the lateral halves of each retina in each eye. It goes from the temporal hemiretina, the optic nerve, and then it goes through the optic chiasm. And anything temporal stays ipsilateral, it does not decussate. And then after it goes to the chiasm, it goes to the optic tract. Again, staying ipsilateral, it finally goes to the lateral geniculate body. And then from there, the fibers go through the optic radiations, including the dorsal optic radiations, as well as the Meyer's lobe, which is also called the lateral optic radiations. And then goes to the primary visual cortex in the occipital lobe. Now the nasal hemiretina is the medial half of each retina in each eye. From there, it goes to the optic nerve, and then from the optic nerve, it would go to the optic chiasm, and then the contralateral optic tract. So it has decussated at the optic chiasm. And then it'll go to the lateral geniculate body, again on the contralateral side, and then it'll go to the optic radiations, and then finally the primary visual cortex. So let's draw this out. So here is figure 8.39 from your text showing the visual pathway. So as you can see, we're looking at the left side, and if you look at the left temporal hemiretina, so this half of the retina, then we'll follow that through the optic nerve, and then it'll go to the optic chiasm, and then it'll stay ipsilateral until it gets to the lateral geniculate body, and then it'll go through the optic radiations. We'll have the Meyer's loop, as we've labeled on this side, and the dorsal optic radiation right here, until it finally reaches the primary visual cortex. Now if we're looking on the right side, we'll just focus on the nasal hemiretina, so this medial half of the retina. It will go through the optic nerve, and then it will decussate at the optic chiasm until it reaches the lateral geniculate body. And of course, it will also go through the dorsal optic radiations and Meyer's loop with the lateral optic radiations until it finally reaches the occipital cortex on the contralateral side. Now the same is true for the right temporal hemiretina. That'll stay ipsilateral, and then the left nasal hemiretina. And then we'll go through the Meyer's loop and dorsal optic radiations and then go to the primary visual cortex. So now let's talk more about the optic radiations. First, the dorsal optic radiations, these traverse the parietal lobe and then synapse on the occipital cortex. Now this carries information from the top half of the retina, which actually ends up being the lower field of vision. And then we have the Meyer's loop, which we can also call the lateral optic radiations, which traverse the temporal lobe, and then finally synapse on the occipital cortex. And this carries information from the bottom half of the retina, which is the upper field of vision. We'll elaborate more on that. So to summarize, if we are looking at the back half of the retina, you can see that the top half, we'll just fill it in here, is responsible for the lower field of vision, because the lower field of vision will reach the top half of the retina. And then the bottom half of the retina, we'll just fill it in this color, is responsible for the upper field of vision. So now if we're just going to focus on the left side for a moment, you can see that the temporal hemiretina is actually responsible for the medial half of the field of vision, as you can see with this arrow. Same thing is true for the medial half of the retina, or the nasal hemiretina. That's responsible for the lateral field of vision. In other words, from the perspective of any point on the retina, the field of vision is upside down and backwards. So this will make more sense after we do some examples. Now, before we jump into some examples, let's talk about how to rock the visual field questions you're going to get on step 1. So one of the first things you need to determine, depending on the question, is know the location of the lesion within the visual pathway. And then you need to know what part of the retina will be dysfunctional. So identify the retina, and then you flip it upside down and backwards, and that will give you the field of vision deficit. So visual field questions will come in a variety of forms. So you may be given the field of vision first, then you think, okay, I need to work backwards, determine, I need to flip that upside down and backwards, and that'll give me what part of the retina is damaged, and then from there you determine the location of the lesion. So you just need to be able to do all 3 of these steps in any order. So let's do an example. So let's get more specific about the lesions. So if you damage this left optic nerve right here, you will get left anopsia. And so if we had the field of vision, we'll just show both eyes. There will be a total deficit in the left eye. So we determine the lesion location, and then we determine the retina deficit. And then finally, we determine the visual field deficit, which means they cannot see out of their left eye entirely. So now let's say we damage the optic chiasm right here. If you damage the optic chiasm, you will lose the signal from the nasal portion of the retina on both sides. So this medial portion, because they try to decussate and they cannot get across. So what would the visual field look like? So they would get bitemporal hemianopsia. So bitemporal meaning they can't see the lateral halves through either eye. So they lost their peripheral vision. So again, this is called bitemporal hemianopsia. So now let's say we damage the dorsal optic radiations on the left side. So that would be these right here. So the next thing we would determine is the retinal dysfunction. Now the dorsal optic radiations are responsible for the upper retina. So the left optic tract right here carried information to the lateral geniculate nucleus from the left side of each retina, which means this right nasal hemiretina, which decussated, and then this left temporal hemiretina, which did not decussate. So we've identified what portion of the retina is damaged. So to summarize, we know we have damaged the dorsal optic radiation on the left side, which means we lost the left, as we determined, the left on each side, and upper. So it's the left upper quadrant of each side of the retina is damaged. So what would be the visual field loss? Well, we just take that, make it upside down and backwards, which would be the right lower quadrant, which means this patient has right lower quadrantic anopsia. So now let's say that the Meyer's loop on the right side is damaged. So we damaged it. So recall that the Meyer's loop carries the signal from the bottom portion of the retina, specifically on the right side of each retina. So the Meyer's loop is responsible for the bottom half. And since we're on the right side, we're only dealing with the right temporal hemiretina and the left nasal hemiretina. So we're only dealing with the right lower portion of each retina. So what would be the visual field loss? Well, it would be upside down and backwards. So we would have lost the left upper quadrant, which means it would be left upper quadrantic anopsia. So now let's say we damage the optic tract on the right side. So right here, the optic tract on the right side is responsible for the right half of the retina in both sides. So right there, right here, because the left nasal hemiretina will decussate and then the right temporal hemiretina will stay ipsilateral. So we know that we lost the right portion of each retina, the right half of each retina in both eyes. So what would be the visual field loss? So if everything's upside down and backwards, the upside down part isn't really relevant here, but the backwards part is. So the patient would actually have a visual field loss on the left side. So it would be left homonymous hemianopsia. For the left homonymous hemianopsia, you can say that the visual field would just look something like this, because the visual field is only really singular in most cases. We just break it down with each eye. So this one, where we damage the Meyer's loop on the right side, the visual field would just look like this. This is what the patient wouldn't be able to see. Same thing with this dorsal optic radiation lesion on the left side. It would simply look like this. And it's a little bit more complicated when we talk about bitemporal hemianopsia, because we just discussed that the patient has lost peripheral vision, and then left anopsia, where the patient simply can't see out of their left eye. So knowing the visual field and the results of any lesion along the pathway is extremely high yield. So we've also created figure 8.40 for your reference. So you can see all of the different lesions and the result of a lesion with this diagram. So now let's apply this knowledge with some questions. Let's say a patient is unable to visualize anything on her left. What part of the visual pathway is likely damaged? So the patient is describing a visual field that looks like this. You can't see on the left side. So what part of the pathway would cause this visual field? So we first need to decide what part of the retina is responsible for the left half of the visual field. We follow the field to the retina, so we can see that the left visual field comes from the nasal hemiretina on the left side, and excites the right temporal hemiretina on the right side, because that would make up the right half of the retina. So it's backwards from the visual field. And then of course it goes to the Meyer's loop and dorsal optic radiations until it reaches the right primary visual cortex. So where along this pathway in red, anywhere in red, where was damaged? Was it the primary visual cortex? Was it the Meyer's loop plus the dorsal optic radiations? And recall, we would have to damage both of them to cause a complete hemiretina, because recall that the Meyer's loop is only responsible for the lower half of the retina, and the dorsal optic radiations are responsible for the upper retina. So we'd have to damage both of them together. Or we could damage the lateral geniculate nucleus, and that would cause this. Or we could have damaged the right optic tract right there. So it's not very likely that it would be the lateral geniculate nucleus. Just to damage that is difficult, it's not very common. And to damage the Meyer's loop plus the dorsal optic radiation at the same time is not really likely, so we're not thinking it's the dorsal optic radiations. But it could be the primary visual cortex, or it could be the optic tract. So without more information, you can't really determine that. But we can safely say that we think it's one of these two. So now let's do another question. Let's say there's an elderly female patient, who has a tumor on the left temporal lobe. So it's on the left. What visual field defect might she have as a result of the tumor? So we're trying to find the visual field defect. So here we are given the tumor in the temporal lobe, so it's the left temporal lobe. Now what part of the visual pathway uses the temporal lobe? Well, that would be the Meyer's loop right here, or the lateral optic radiations. So we are dealing with the left hemisphere of the brain. So if a temporal lobe tumor damaged the Meyer's loop, this patient would lose the function of the lower retina, and this would be on the left and right side. Because think this side, the temporal hemiretina uses that, and then the right nasal hemiretina will also use that. So what would be the visual field defect if she lost the lower quadrant of each retina? Well, we just take that upside down and backwards, and the visual field defect would be the right upper quadrant. So this would be right upper quadrantic anopsia. So the macula is a part of the retina. It's the, again, center field of vision, and it's the center of the retina, essentially. So macular degeneration would lead to central loss of vision. Now the portion of the occipital cortex devoted to the macula is supplied by the middle cerebral artery. So if you have a posterior cerebral artery that damages the occipital cortex, then we will have macular sparing. It'll spare the macula. And we'll explain this situation in a little bit more detail when we get to the vascular portion of this lecture. So let's say there's a 64-year-old female patient who complains of a blurry spot in the middle of her vision. Where is their damage likely to be? So this patient is complaining of central loss of vision, which looks like that. So right there in the center, she cannot see. So this should instantly make you think of the macula. So central loss of vision should also make you think of the occipital cortex. So you could have damaged back here if there was a MCA infarct, or you'd have damage to the center part of the retina. So this will make more sense after we talk about the blood supply to the visual pathway. So we have the retina, which is supplied by the ophthalmic artery. And the ophthalmic artery comes from the internal carotid. It's a branch of that. And the optic nerve and then the chiasm are innervated by branches of the anterior cerebral artery. And then the optic tract is supplied by the anterior choroidal arteries, which are part of the MCA, and then the posterior communicating arteries. The lateral geniculate nucleus is supplied by the anterior choroidal, which is a portion of the MCA, just like the optic tract. And it's also supplied by the posterior choroidal arteries from the ACA. And the optic radiations, so the dorsal optic radiations and the Meyer's loop, are supplied by both the MCA and the PCA. And the occipital cortex is supplied by the PCA, or posterior cerebral artery. So as you can see, there's quite a bit of crossover between what arteries supply each portion of the visual pathway. For example, if a patient gets a right PCA infarct, they will likely demonstrate left homonymous hemianopsia with sparing of the macula. However, with an MCA infarct, it's not perfectly clear what parts of the visual pathway could be affected, if at all. For example, the MCA supplies the lateral geniculate nucleus, but so does the ACA. Another example is the MCA supplies the optic radiations as well as the PCA. The point is that determining what portion of the visual pathway is damaged based on a certain type of stroke is not realistic. So don't spend too much time memorizing the blood supply of the visual pathway. Just know two things. The occipital cortex is supplied by the PCA. Next, know that the ophthalmic artery is supplied by the internal carotid, and that supplies the retina. Those are the two highest yield things you need to know about the blood supply to the visual pathway. So if you know those two things, you'll be in great shape for step one. Now this is figure 8.41, which is just for your reference. Again, what you need to know is the occipital cortex, back here, is supplied by the posterior cerebral artery. So know this box. And know that the retina, this box, is supplied by the ophthalmic artery, which is a branch of the internal carotid. So know those two portions. So I'll ask you a question. Let's say there's a 73-year-old male patient who is found unconscious on his living room floor. After regaining consciousness, he complains of loss of vision on the left side with full vision in the center. Neurologic imaging indicates a stroke. Where was the stroke likely to be? We got to identify where the stroke is. So let's look at the visual pathway again. So if his visual field is essentially looking like this should make you think of two things: damage to the optic tract on the right side, or damage to the occipital cortex on the right side. And again, we're thinking right because the right hemiretina is responsible for the left field of vision, because again, we go upside down and backwards. And again, we're not thinking that he just damaged the Myers loop with the dorsal optic radiations, because if one of these two would be damaged, then we would just lose a quarter of vision, not a complete half of vision, and damaging them both at the same time is just not realistic. He also stated that he can see the center just fine. In other words, there's sparing of the macula. So in other words, this is macular sparing. So this implicates a PCA infarction, which means we're thinking the right occipital lobe is what was damaged. So going back to our question, in a patient with left homonymous hemianopsia with sparing of the macula, the patient is likely to have had a PCA infarct, which is where we think the stroke is. Now let's talk about the parasympathetic innervation of the eye. Just remember that the parasympathetic innervation of the eye is mediated by cranial nerve 3, the oculomotor nerve. So innervation starts in the midbrain with the Edinger-Westphal nucleus, then the ciliary ganglion, and the short ciliary nerve, which innervates the pupillary sphincter muscle. When activated, it constricts the pupil and causes miosis. And then the other thing is accommodation, which follows the same path, the Edinger-Westphal nucleus in the midbrain, ciliary ganglion, short ciliary nerve to the ciliary muscle, which performs accommodation. It's accommodation of the lens. So here's figure 8.42, showing the parasympathetic innervation of the eye. As you can see here, we have the Edinger-Westphal nucleus, which sends fibers through the ocular motor nerve, right here. We have labeled nucleus. Then the ocular motor nerve sends a signal to the ciliary ganglion, labeled right here. Then the ciliary ganglion sends fibers to the pupillary sphincter muscle, this blue line, which is labeled right here on the left side, and it causes miosis. We will talk more about the pupillary light reflex and the role of the pupillary sphincter muscle later in this lecture. For now, just focus on the parasympathetic innervation of the eye in general. The next thing to know is that the ciliary ganglion can also innervate the ciliary muscle surrounding the lens. So this green line on this left side and on the right side. And when the ciliary muscle is stimulated, it will cause accommodation of the lens. Now, accommodation just means you can change the shape of the lens to properly focus objects on the retina. We're not going to talk much more about accommodation, but it's important to know that it is accomplished through the parasympathetic innervation of the eye via the ocular motor nerve. So now let's talk about the pupillary light reflex. So the retina receives the light stimulus, and then the cranial nerve 2, or the optic nerve, will send information to the pretectal nucleus in the midbrain. From the midbrain, fibers travel to the ipsilateral and contralateral Edinger-Westphal nucleus. From there, the cranial nerve 3, or the oculomotor cranial nerve, sends fibers to the ciliary ganglion bilaterally, so both sides. And then from there, the short ciliary nerve carries information to the pupillary sphincter muscle, and then the patient gets miosis. And I want you to pay special attention to the fact that it's ipsilateral and contralateral and then bilateral. Point being is that light can come in from the right side, but both the right and left eye will cause pupillary constriction or miosis. So let's draw this out. So here is figure 8.43, showing the pupillary light reflex. So light will reach the retina in the back of the eye. We'll just focus on this right side for now. And then it will travel to the pretectal nucleus, following the optic nerve down to this pretectal nucleus back here. So in this case, it'll hit the right side. Again, this is within the midbrain. Keep in mind that the nasal hemiretina on the right side sends fibers that decussate at the chiasm and synapse on the left pretectal nucleus in the midbrain. In other words, both pretectal nuclei will be stimulated from the afferent signal in the right eye. For this illustration, to keep things from getting too messy, let's just focus on this right pretectal nucleus, but recognize that both are stimulated. And then fibers will travel from this pretectal nucleus to the Edinger-Westphal nucleus on both sides. So it's bilaterally at this point, as you can see in this image. From there, cranial nerve 3 carries parasympathetic innervation to the ciliary ganglion. And from the ciliary ganglion, the short ciliary nerves will carry the stimulus to the pupillary sphincter muscle. So the pupillary sphincter muscle will be activated and will lead to miosis of both eyes. So as you can see, if you shine a light into the patient's right eye, then the Edinger-Westphal nucleus on both sides will be stimulated. So both pupils will constrict. This pathway is super important and very clinically relevant, not to mention a goldmine for examiners writing test questions for step 1. So let's just work through a few questions to help you get prepared for how you might be tested. Okay, so a patient has severe retinal detachment of the left eye. How will the right eye respond when light is shown through the left eye? Okay, so looking at this image, the patient has retinal detachment of the left eye. So we are thinking there is damage to the afferent part of the pupillary light reflex through that eye. And afferent is simply referring to the optic nerve, because the optic nerve is what carries the signal to the midbrain. So if the optic nerve is not sending the signal to the pretectal nucleus on the left side, then there will be no stimulation of the Edinger-Westphal nucleus on either side. So going back to our question, what will happen to the right eye when light is shown through the left eye? The answer is nothing, because neither pupil received the stimulus to constrict. If we extended the question a bit further, we could ask what would happen to the left eye if light was shown through the right eye. In this case, the afferent signal and the efferent signal would be fully intact. So the right optic nerve would be able to get the signal to the midbrain and to the pretectal nucleus on the right side. And if the efferent signals are intact, that means the pretectal nuclei will be able to send the signal to the Edinger-Westphal nucleus on both sides and stimulate the ocular motor nerve. And then the ciliary ganglion will be stimulated, and both pupillary sphincter muscles will be stimulated, causing constriction of the pupils in both eyes. So what we've decided is that if you shine light into the right eye, both eyes will constrict. But if you shine light into the left eye, the eye with a retinal detachment, neither eye will constrict. A name for this syndrome is Marcus-Gunn pupil, or an afferent pupillary defect, APD. This simply means that the afferent limb of the pupillary light reflex is dysfunctional, causing neither pupil to constrict when light is shown through the eye with a defect. Let's do another question. Let's say a patient is unconscious following a car crash. The medic on site shines light in both eyes without any constriction of either pupil. If brain damage caused the failed pupillary light reflex, what structure would be implicated? Okay, so basically a medical worker sees an unconscious patient and sees that the pupillary light reflex is not working in either eye. Now this is a test used to determine if the brainstem is functional in an unconscious patient. If we look at the pathway of the light reflex, we can see that the portion of the brain responsible for the reflex is the midbrain. So if there's damage to the midbrain, you won't ever get a signal to the pupillary sphincter muscles in either eye. So going back to the question, if brain damage caused the failed pupillary light reflex, the structure responsible would be the midbrain. So now let's talk about the horizontal gaze pathway for the eyes. So the signal starts in the right frontal eye field. We're just using right as an example now, but obviously this would apply for the left frontal eye field as well. So from the right frontal eye field, it will decussate to the left perimedian pontine reticular formation, or the PPRF, located in the pons. And then from there, it'll go to the left abducens nucleus, or cranial nerve 6, which is also in the pons. And from there, it'll go to the right medial longitudinal fasciculus, or the MLF. So it is now decussated back to the other side, and it'll innervate the right medial rectus subnucleus, cranial nerve 3, within the midbrain. So the net effect is that the left lateral rectus muscle and the right medial rectus muscle were stimulated at the same time, causing both eyes to look left. So if we were to insert the word left right here, and we started with the left frontal eye fields, we'd just reverse every one of these terms, and the eyes would finally actually look right. So let's draw this out to make it simpler. So here's figure 8.45 from your text, showing the horizontal gaze pathway. So as mentioned in the previous slide, if the patient wants to look to the right, the signal will start in the left frontal eye field and travel to the perimedian pontine reticular formation on the right. And then it will stimulate the right abducens nerve, and then it will also stimulate the left medial longitudinal fasciculus. So the net effect is that the left ocular motor nucleus, as well as the medial rectus muscle, will be stimulated at the exact same time as the cranial nerve 3 and the lateral rectus muscle are stimulated. So the patient will look to the right. Now this is a super high yield concept. So if you damage this left medial longitudinal fasciculus, then when a patient looks to the right, the left eye will stay focused in the center, and then the right eye will deviate to the right, because the medial longitudinal fasciculus was never stimulated on the left side. So the left ocular motor nucleus can never be stimulated, so the left medial rectus muscle can never be stimulated. So when a patient has one eye looking to the right and one eye continuing to look straight, they will complain of double vision. However, the medial rectus muscle is actually fully functional. For example, if you ask a patient to look at your finger as you bring your finger closer to their nose and finally touching it, both eyes will converge, which means the medial rectus muscle on both eyes were stimulated, causing both eyes to look inward. This is called convergence. And this is possible because the medial rectus muscles in both eyes still work. What wasn't functional in this patient was the medial longitudinal fasciculus, which means that having both eyes move in the same direction, for example, to the right, is not possible because the medial longitudinal fasciculus is not carrying the signal. This is a concept to know backwards and forwards, so get familiar with this diagram. Let's do some questions to apply this. So let's say the left medial longitudinal fasciculus is damaged. What will happen to the patient when they look to the left? So when we look at this diagram, we know that if the left medial longitudinal fasciculus, going from here to here, if that's broken, then the cranial nerve 3 will never be stimulated, meaning that the medial rectus muscle on the left side will not be stimulated. So as we mentioned in the previous slide, when the patient looks to the right, they will get double vision. This means that this patient has a left INO, or left internuclear ophthalmoplegia. Also, the right eye will be overstimulated in an attempt to correct this left INO. So the right eye will demonstrate nystagmus, or repetitive uncontrolled movements. However, when the patient is trying to look to the left, which means the right frontal eye field will be stimulated, decussate to stimulate the perimedian pontine reticular formation in the left side, to then stimulate at the abducens nucleus. It will also go to stimulate the right-sided medial longitudinal fasciculus, which will stimulate the right cranial nerve 3, which will stimulate the right medial rectus muscle. So the patient can look left just as normal, because we did not need the left medial longitudinal fasciculus in order to look left. So going back to our question, when the patient looks left, what will happen? Nothing abnormal. Let's do another question. So let's say a patient demonstrates right-sided internuclear ophthalmoplegia. When will she likely experience double vision? So if you hear the term right-sided INO, you should immediately think of the right medial longitudinal fasciculus. So when a patient is trying to look to the left, the medial rectus muscle of her right eye will not adduct as it should, resulting in the right eye remaining straight and the left eye abducting. So both eyes will be looking at different locations, resulting in double vision. So in answer to our question, with the right medial longitudinal fasciculus being damaged, when the patient tries to look left, they will get double vision. So now let's extend the question. So a patient demonstrates right-sided INO and experiences double vision when looking left. So convergence is intact. Now where in the brain is the lesion? So we have determined that the patient has a right-sided INO, so we are thinking of the right medial longitudinal fasciculus and that it is damaged. So she gets double vision when she's looking to the opposite side or the left side. So in this scenario, what we want to do now is identify where in the brain the lesion is. So we have here a picture of the midbrain and the pons. In which one is the medial longitudinal fasciculus? We'll recall that it is in the same part of the brainstem as cranial nerve 6, so in the pons. So we have the abducens nucleus pointing to cranial nerve 6, and we have that on both sides. So now focusing on the pons, we know that the medial longitudinal fasciculus should be very close to the abducens nucleus. And the medial longitudinal fasciculus is located very medially, the most medial portion. So if we draw a line down the center, it would be the most medial portion and close to the fourth ventricle. So we're actually suspecting these two right here. As you recall from the cranial nerve lecture, all of the motor nuclei are located close to the center, medial to the sulcus limitans, and all these sensory nuclei are located more laterally. So we've identified where in the brain the medial longitudinal fasciculus would be. We're thinking it's these two, and it is in fact labeled here. But what medial longitudinal fasciculus would it be? Would it be the one on the right or the one on the left? Well, as we determined, if you have right-sided INO, then you have damage to the right medial longitudinal fasciculus. So we're thinking the one on the right. So of course, the medial longitudinal fasciculus travels to the midbrain, to the cranial nerve, but there's really not an identifiable pathway that's easy to identify, especially on a test in the midbrain. So that's why we're not really trying to identify the tract of the medial longitudinal fasciculus within the midbrain, so we've really just identified it easily in the pons. So now to review, internuclear ophthalmoplegia. So if you have a right internuclear ophthalmoplegia, then you have right medial longitudinal fasciculus damage. So you get double vision when looking to the opposite side, so looking left. And then you will get nystagmus of the left eye. So recall that nystagmus is repetitive, uncontrolled movements of the eye. So if you have nystagmus of the left eye, that just means that cranial nerve 6, which is fully intact on the left side, is overstimulated. So this patient is getting double vision when looking to the left, so the left cranial nerve 6 will be overstimulated, and the lateral rectus muscle will be overstimulated, leading to repetitive, uncontrolled movements when looking to the left, to try to correct that double vision. Conversely, with left INO, that means that there's left medial longitudinal fasciculus damage, so they'll get double vision when looking to the opposite side, so when looking to the right, which means you'll get nystagmus of the right eye, because the right cranial nerve 6 is overstimulated. And recall that the medial longitudinal fasciculus and cranial nerve 6 are located in the medial part of the pons. Then cranial nerve 6 is located in the medial midbrain. So now let's talk about the sympathetic innervation of the eye. So sympathetic innervation starts in the hypothalamus, then it goes through the lateral tegmentum of the brainstem, and then it synapses in the lateral horn gray matter of C8 through T2. And it exits at T1, and then from there it enters the sympathetic chain. And then it synapses on the superior cervical ganglion at C2. Then it goes through the long ciliary nerve to the pupillary dilator muscle, which causes dilation of the pupil, so mydriasis. Now the superior cervical ganglion actually also sends innervation to the superior tarsal muscle, which causes lid retraction. Now the superior cervical ganglion also sends fibers to the sweat glands to cause sweating, and the blood vessels of the face to cause constriction. So here's figure 8.44, showing the sympathetic innervation of the eye. As you can see, the signal starts in the hypothalamus, then it travels down the hypothalamo-spinal tract, and it uses the lateral tegmentum in the brainstem. Now it's very important that you recognize that this tract uses the lateral tegmentum in the brainstem in order to get to the spinal cord down here. And the reason this is important is because you can then determine why strokes will disrupt this pathway, because there's vascular supply to the lateral tegmentum. If you damage that, you're damaging the oculosympathetic pathway. The vasculature and strokes are discussed later in this chapter. So once the first neuron gets to the ciliospinal center of Budge, here we just have written the ciliospinal center and the lateral horn of the gray matter, which is C8 to T1, then through T1, spinal cord T1, which is this right here. This second neuron will exit the sympathetic trunk, and it's also called the preganglionic fiber. And it will travel up through the sympathetic trunk until it reaches the superior cervical ganglion, and from there it will synapse, and a nerve will leave the ganglion to innervate the pupillary dilator muscle, which causes mydriasis. So disruption of this sympathetic innervation will cause meiosis, or constriction of the pupil. The superior cervical ganglion also sends fibers to the superior tarsal muscle, which causes lid retraction. So with damage to the sympathetic innervation to this muscle, a patient will demonstrate ptosis, or drooping of the eyelid. It's also important to know that the superior cervical ganglion innervates the blood vessels of the face, causing constriction of the blood vessels. So denervation to this pathway would cause dilation of the blood vessels of the face, causing flushing. The superior cervical ganglion also innervates the sweat glands of the face. So if you damage that, then you're not going to have sweating. So as you can see, if you do any damage to the subclavian artery, or you get a Pancoast tumor, or you damage the jugular region or carotid region of the neck, then you could get Horner syndrome, leading to anhidrosis, flushing of the face, meiosis, and ptosis. So let's talk a little bit more about Horner syndrome. So if you have loss of the long ciliary nerve innervation, you're no longer going to get mydriasis, or activation of the pupillary dilator muscle, so you're going to get meiosis. If you lose innervation to the superior tarsal muscle, then you're no longer going to have lid retraction, so you're going to get ptosis. And if you lose sweat gland innervation, you're no longer going to be able to sweat with the face and forehead, so you're going to get anhidrosis. And if you lose vasoconstriction of the face, then you're going to get vasodilation, and the patient's going to be flushed. So some people like to remember Horner syndrome by just saying meiosis, ptosis, and anhidrosis. You can also think of vasodilation because of the flushing. So let's do a question. Let's say a patient develops right-sided ptosis and meiosis. This is on the right side. And this is secondary to Brown-Séquard syndrome. What was damaged, the postganglionic or the preganglionic sympathetic fibers? So this patient has Horner syndrome because they have ptosis and meiosis. So right-sided Horner syndrome. So is it the postganglionic or the preganglionic fibers that are the culprit? So if we look at this figure once again, recall that the preganglionic fiber cell body is in the lateral horn of the gray matter in the spinal cord, and it then enters the sympathetic chain until it reaches the superior cervical ganglion. So this is the preganglionic. Within the superior cervical ganglion are the cell bodies for the postganglionic fibers, which then leave to the tissues that they innervate. These are all postganglionic fibers. So in Brown-Séquard syndrome, which fiber would be damaged, the pre or the postganglionic fiber? We'll recall from section 2 of this chapter that Brown-Séquard syndrome is a spinal cord defect resulting in damage to an entire half of the spinal cord at a specific level. So it's a complete hemisection. So once you see it in those terms, you can clearly see the postganglionic fibers are not even touched by the Brown-Séquard syndrome. Rather, the preganglionic cell body is damaged. If the question stem indicated that a surgery was being performed on the neck near the jugular vein or the carotid artery or carotid sheath, so anything in this region, and then the patient developed Horner syndrome, we would actually suspect the postganglionic fibers. And that's actually really high yield to know. So if there's anything going on in the patient's neck, any surgery, any procedures, or anything, and the patient develops Horner syndrome, always think of postganglionic fiber damage. So now let's talk about the vertical gaze pathway. So it starts in the superior colliculus, which is responsible for ensuring that both eyes move up and down together, so conjugate gaze. The superior colliculus is located on the dorsal midbrain, and it can be damaged by a pineal gland tumor. So let's demonstrate this visually. So here on the left, we have figure 8.16, and on the right we have figure 8.3, both of which were discussed previously in this chapter. So looking at figure 8.16, if we're looking at the dorsal or posterior aspect of the midbrain, we can identify the superior colliculi. So if we're looking at figure 8.3, we can see the superior colliculus right here is just inferior to the pineal gland. So it would stand to reason that in the case of a pineal gland tumor, the superior colliculus could easily be compressed, resulting in damage to the vertical gaze pathway, causing vertical gaze palsy. So now let's just briefly talk about the ocular muscles. So the medial rectus muscle will adduct the eye, and the lateral rectus muscle will do just the opposite. It'll abduct the eye. And the superior rectus muscle will elevate the eye, and the inferior rectus muscle will depress the eye. And that's all pretty straightforward. Now when we start talking about the oblique muscle, starting with the superior oblique muscle, this will actually abduct the eye, and then it will depress the eye, bring it lower, and it will internally rotate the eye, which is also called intorsion. So if we have both eyes right here, the superior oblique, which comes in, when it's stimulated, it will cause the eye to move in, intorsion. So the inferior oblique, similar to the superior oblique, will abduct the eye, but it's opposite in that it will elevate the eye and externally rotate the eye, or extorsion. So when the inferior oblique comes, this is where it's located, and when it's stimulated, it'll cause the eye to move out that way, so extorsion. So this is just a brief overview of the ocular muscles. It's pretty straightforward, and you just think that if you damage the medial rectus muscle, you won't be able to adduct as much. So if we're looking at the eyes, if you damage the medial rectus muscle of the right eye, you're not going to be able to look medially with the right eye. Then if you damage the lateral rectus muscle of the right eye, you're not going to be able to look laterally. Then the same principle is true for the superior and inferior rectus muscles. And if you damage the superior oblique muscle, this right here, then the eye would not be able to abduct, look this way, depress, look this way, or internally rotate. So essentially, the eye would look up in this direction. And this situation is discussed in great detail in the cranial nerves lecture of this chapter. So the innervation, which is discussed in great detail in the cranial nerve lecture of this chapter, can also be remembered via this little mnemonic. So it's almost like a chemical formula. So the lateral rectus muscle is innervated by cranial nerve 6. The superior oblique muscle is innervated by cranial nerve 4, and all the rest are innervated by the ocular motor nerve, cranial nerve 3. So LR6, SO4, R3 is just a quick way to remember it. But some quick things to remember is that if you damage the lateral rectus muscle, the lesion will lead to medial deviation of the eye. If you damage the superior oblique muscle, the lesion will lead to medial upward deviation, which we discussed on the previous slide. And the rest, cranial nerve 3, if you lesion that, then you'll get a lateral downward deviation plus mydriasis. So if let's say we damage the right side, right here on the right, then we get mydriasis, blown pupil, if you will, and then you would get a lateral downward deviation. The eye would look down that way. And that concludes this section.
Welcome to section 9 of neurology. In this section, I will be discussing the neurovasculature. The section is divided into two parts. In the first part of the section, I'll be providing an overview of the neurovasculature, and in the second part, I'll focus on examples and integrating the remaining material. Let's get started. This is figure 8.46 from your text, which provides a general overview of the neurovascular anatomy. I'm not going to read each structure to you, but it's very important for you to take some time to memorize the anatomy from this figure. We'll talk about these vessels in more detail as we go through practice questions, but recognize that each vessel in this image has clinical significance and has an important physiologic tie-in for step 1. Also, before we dive deeper into the anatomy, I'd like to mention that once the vasculature reaches the brain, its composition slightly changes into what's known as the blood-brain barrier. For step 1, you need to know that the blood-brain barrier is composed of 3 things: the endothelial cells, astrocytes, and pericytes. Okay, now let's zoom up on this region here. This is figure 8.47 from your text, which shows a close-up view of the circle of Willis. Again, I'm not going to read the labels from this image, but you will need to take some time to commit this to memory. Hopefully, as we go through some questions, the anatomy will become solidified and these images will become easy to recall. This is figure 8.48 from your text, which shows the important neurovascular territories. I recognize that the entirety of this figure is difficult to see on a single slide, so we'll break this figure up into 5 separate slides. However, this figure should be very clear in your text, which should allow you to easily review the material. Notice that only the vascular territories of 3 arteries are shown in this figure: the posterior cerebral artery, the middle cerebral artery, and the anterior cerebral artery. As we go through each component of this figure, I won't read the labels to you, but hopefully you'll pause the video and take some time to memorize what arteries supply the different territories of the brain. This is a lateral view of the neurovascular territories. This is an inferior view of the neurovascular territories. This is a mid-sagittal view of the neurovascular territories. This is a transverse view of the neurovascular territories. This is a coronal view of the neurovascular territories, which is probably the most important view to be familiar with. This is because when we combine this image with the homunculus, we can deduce many of the symptoms that a patient should experience if one of the vessels feeding these territories was occluded. Again, this is figure 8.6, which shows the homunculus. Remember, this image represents both the primary motor and primary sensory cortices. From the last slide, we know that this region here is fed by the anterior cerebral artery, or ACA. So you can imagine if the patient had a stroke of the ACA, then he or she would experience paralysis and sensory deficits of the leg. Because the motor and sensory pathways decussate, we should be able to deduce that occlusion of the left anterior cerebral artery would result in paralysis and sensory deficits of the right lower limb. Again, from the last slide, we know that this region here is supplied by the middle cerebral artery, or MCA. This means occlusion of the MCA would result in contralateral paralysis and sensory deficits of the upper limb, face, and mouth. The posterior cerebral artery, or PCA, doesn't supply blood to the primary motor and sensory cortices, so the homunculus can't help us here. However, the PCA supplies blood to the occipital cortex, which is responsible for vision, so occlusion of the PCA should result in visual deficits, which is discussed more in Section 8. Recall from Section 8 that the MCA supplies blood to the macula of the eyes, so occlusion of the PCA would result in visual deficits with sparing of the macula. This is figure 8.49, which provides a coronal view of the lenticulostriate arteries. Notice that the lenticulostriate arteries are branches of the middle cerebral arteries. So we have the right middle cerebral artery and the left middle cerebral artery. It's important to know that the lenticulostriate arteries supply blood to the internal capsule and basal ganglia. We can see the internal capsule right here, as well as the basal ganglia. We have the putamen, the globus pallidus, the caudate nucleus, and the thalamus. Knowing this, we can deduce the symptoms a patient may have if these arteries are damaged. Damage to the internal capsule would result in contralateral paralysis and sensory deficits. This is because the corticospinal tract and the thalamocortical tracts pass through the internal capsule. Damage to the basal ganglia would result in movement abnormalities, which are highly variable depending on the region that's damaged. For more information on the details of the basal ganglia, refer to Section 6. For Step 1, it's important to know that the lenticulostriate arteries are commonly affected in patients with chronic hypertension, which we'll talk about more later. This is Table 8.4 from your text, which provides an overview of the effects of strokes. We just discussed the anterior cerebral artery, the middle cerebral artery, the lenticulostriate artery, and the posterior cerebral artery. So I'm not going to cover that again, but feel free to pause the video and review that information from the table. The basilar artery is a major vessel that supplies blood to the midbrain, pons, and medulla. So all of these regions are damaged during an occlusion. Because there are so many areas of the brainstem that are damaged during a basilar artery occlusion, I find it most helpful to remember the structures that aren't damaged. These include the oculomotor nerve, so cranial nerve 3, and the reticular activating system. Recall that cranial nerve 3 allows the eyes to move vertically, so vertical eye movement is intact. Cranial nerve 3 also innervates the levator palpebrae superioris muscle, which is responsible for opening the eye. Because this muscle is under conscious control, patients can relax the muscle, causing the eye to close. This is why patients with a basilar artery occlusion can blink, so blinking is intact. For Step 1, it's important to know that the reticular activating system includes the reticular formation and the tegmentum. Let's pull up some images to make this a little clearer. From figure 8.46, we can see the basilar artery is right here. Notice how the basilar artery is in the midline of the brainstem and supplies blood to the medulla, pons, and the midbrain. This is figure 8.16, which is a transverse section of the midbrain. This is anterior, and this is posterior. From the last image, we know that the basilar artery is about right here. The branches of the basilar artery dive deep into the brainstem, so much of the anatomy is affected. However, the oculomotor nerve, right here, is one of the deeper structures of the midbrain and is typically not damaged during occlusion of the basilar artery. This is why patients can blink and move their eyes vertically. The reticular formation is a group of many nuclei throughout the brainstem, so it can't be easily identified on one image like this. The tegmentum is also a general area within the brainstem, but on this section of the midbrain, it's located throughout this region of the white matter here. Notice how it's a general area between the cerebral aqueduct and the substantia nigra. Both the reticular formation and the tegmentum are involved in sleep-wake cycles and are important in preserving consciousness. Because these structures are so ubiquitous, they're typically somewhat preserved during an occlusion of the basilar artery, which explains why the patient can have preserved consciousness. Okay, moving on to the anterior inferior cerebellar artery. Occlusion of this artery is also called lateral pontine syndrome. Because the lateral pons is damaged, we'd expect all the structures in this region to be affected. Let's pull up some images to more clearly see what structures are damaged. From figure 8.46, we can see that the anterior inferior cerebellar artery is right here. Notice how this artery wraps around the lateral aspect of the pons. This is why when it's occluded, the lateral pons becomes ischemic, hence the name lateral pontine syndrome. From figure 8.18, which shows a transverse section of the pons, we can more clearly identify the structures that would be damaged in lateral pontine syndrome. This is anterior, and this is posterior. So again, the anterior inferior cerebellar artery supplies blood to the lateral pons, or approximately this region here. For this syndrome, it's most important to remember that the facial nucleus and the solitary nucleus are damaged. Damage to the motor aspect of the facial nucleus will result in total ipsilateral facial paralysis. Recall that the solitary nucleus contains sensory information from cranial nerves 7, 9, and 10. Knocking out the sensory aspect of the facial nerve would result in taste deficits from the ipsilateral anterior 2/3 of the tongue. Knocking out sensory aspects of cranial nerves 9 and 10 would result in more vague symptoms such as abnormalities associated with the monitoring of the baroreceptor and chemoreceptor reflexes. So again, facial paralysis and taste deficits from the anterior 2/3 of the tongue are symptoms unique to lateral pontine syndrome. Also notice several other structures in the lateral pons, including the vestibular nuclei, the spinothalamic tract, and the middle cerebellar peduncle. The inferior cerebellar peduncle can also be damaged, which can't be seen on this image, but it's directly inferior to the middle cerebellar peduncle. In order to see this, we'd have to take a cross-section of the caudal pons. It's also worthwhile mentioning that the lateral tegmentum, or this general area in the white matter here, can be damaged, which contains descending fibers from the hypothalamospinal tract. Recall that this tract contains important sympathetic information that will return to the face, so damage to this region can result in Horner syndrome. Damage to each of these structures explains the other symptoms associated with lateral pontine syndrome, which you can review from table 8.4 if you'd like. However, many of the symptoms seen in this syndrome are identical to lateral medullary syndrome, so it's important to know that damage to the facial nucleus and the solitary nucleus are unique to this syndrome. Okay, let's move on to lateral medullary syndrome. The posterior inferior cerebellar artery, or pica, is an important vascular contributor to the lateral medulla. For this reason, occlusion of this artery is also called lateral medullary syndrome. It's important to know that the pica is a direct branch of the vertebral artery, so occlusion of the vertebral artery can also result in lateral medullary syndrome. Because the lateral medulla is damaged, we'd expect all the structures in this region to be affected. Let's pull up some of the figures to more clearly see what structures are damaged. From figure 8.46, we can see that the posterior inferior cerebellar artery, or pica, is right here. Notice how this artery wraps around the lateral aspect of the medulla. Also notice that the pica is a direct branch of the vertebral artery. This is why when the vertebral artery or the pica are occluded, the lateral medulla becomes ischemic. From figure 8.20, which shows a transverse section of the medulla, we can more clearly identify the structures that would be damaged in lateral medullary syndrome. Again, this is anterior and this is posterior. The pica supplies blood to the lateral medulla, or approximately this region here. For this syndrome, it's most important to remember that the nucleus ambiguus is damaged. Recall that the nucleus ambiguus contains motor information from cranial nerves 9 and 10. From section 3, recall that cranial nerves 9 and 10 provide motor output to the pharynx and larynx, so damage to these structures would result in dysphagia and dysphonia, or difficulty eating and difficulty speaking. Also notice several other structures in the lateral medulla, including the vestibular nuclei, the spinothalamic tract, and the inferior cerebellar peduncle. Also note that the lateral tegmentum, or this general area here within the white matter, can also be damaged, resulting in Horner syndrome. Damage to these structures explains the other symptoms associated with lateral medullary syndrome, which you can review from table 8.4 if you'd like. However, many of the symptoms seen in this syndrome are identical to lateral pontine syndrome, so it's most important to know that damage to the nucleus ambiguus is unique to this syndrome. Okay, the last artery to be familiar with is the anterior spinal artery. Let's pull up some images to more clearly see what structures are damaged. From figure 8.46, we can see that the anterior spinal artery, or ASA, is right here. Notice from this image, and from the name of the vessel, how this artery supplies blood to the anterior aspect of the spinal cord. However, it's also important to know that branches from the ASA, called paramedian branches, supply blood to the medial aspect of the medulla. Let's look at a cross-section of the medulla to see what structures are affected. On this slide, we have figure 8.20, which shows a transverse section of the medulla. It's important to know that the paramedian branches of the ASA supply blood to approximately this region right here. Notice how these arteries supply the medial aspect of the medulla, and the most medial arteries extend relatively deep into the medulla, as we can see right here. As we can see, the hypoglossal nucleus is right here. And because this nucleus is so medial and deep, it can become ischemic during occlusion of the ASA or the paramedian branches of the ASA. Also notice how the medial lemniscus, right here, and the corticospinal tract, right here, are both medial and receive blood directly from the paramedian branches of the ASA. Recall from table 8.4 that these are the three structures that are damaged during an occlusion of the ASA. Also remember from section 3 on cranial nerves that damage to the hypoglossal nucleus results in tongue deviation to the ipsilateral side. Recall from section 2 on spinal tracts, figure 8.13, which outlines the pathway for the dorsal column. As we can see from this image, the dorsal columns ascend through the medial lemniscus and are responsible for vibration and proprioception. So damage to the medial lemniscus in an ASA stroke would result in contralateral loss of vibration and proprioception. Note that loss of sensation is contralateral because the pathway decussates before the medial lemniscus, as we can see right here, decussation. Also recall from section 2 on spinal tracts, figure 8.15, which outlines the pathway for the corticospinal tract. As we can see from this image, the corticospinal tract descends through the anterior pyramids and is responsible for movement. So damage to the anterior medulla in an ASA stroke would result in contralateral paralysis. Note that the paralysis is contralateral because we're assuming the pathway is damaged at this region. Okay, before we move on to aneurysms, I'd like to briefly mention another type of lesion associated with the ASA. This is figure 8.9, which shows a cross-section of the spinal cord. After the ASA descends past the medulla, it supplies blood to approximately this region here. Notice how this vascular territory supplies the anterior and lateral aspects of the spinal cord, but spares the dorsal columns. This means if the blood supply is compromised, the patient will present with bilateral paralysis due to disruption of the corticospinal tracts, bilateral loss of pain and temperature due to disruption of the spinothalamic tracts, and intact proprioception and vibration due to sparing of the dorsal columns. For step 1, you need to know that there are several anastomoses between the ASA and other arteries that supplies collateral circulation to this region. This is important because it means an occlusion of one of these vessels is less likely to cause significant ischemia to the spinal cord. So if you ever get a question about damage to the spinal cord with sparing of the dorsal columns, it will likely be in the context of hypoperfusion to the ASA and its collateral circulation. Okay, let's move on to aneurysms. An aneurysm is simply a balloon-like dilatation of an artery. There are two types of aneurysms you need to be familiar with for step 1. Saccular, or Berry aneurysms, and Charcot-Bouchard microaneurysms. Saccular aneurysms are relatively large and are commonly associated with connective tissue disorders, such as Ehlers-Danlos syndrome, smoking, and age. It's important to know that these aneurysms can either rupture or can compress nearby structures. If they rupture, they can cause a subarachnoid hemorrhage and or ischemia to the nearby region. If they compress nearby structures, the patient may have clinically significant symptoms, but this depends on the location of the aneurysm. On the other hand, Charcot-Bouchard microaneurysms are microscopic dilatations of arteries that occurs as a result of chronic hypertension. It's important to know that this type of aneurysm most commonly occurs in the lenticulostriate arteries. This is table 8.5 from your text, which provides a list of clinically relevant aneurysms and the associated lesion area and symptoms. An aneurysm of the MCA, or the lenticulostriate arteries, are essentially identical to a stroke in these regions, which is clearly explained in table 8.4, so I'm not going to repeat this information. For step 1, you need to know that rupture of an aneurysm originating from the anterior communicating artery, or ACOM, can result in ischemia to the anterior cerebral artery, or ACA distribution. Again, we already discussed a stroke of the ACA in table 8.4, so I'm not going to repeat that. You also need to know that a saccular aneurysm originating from the ACOM can compress the optic chiasm, resulting in bitemporal hemianopia. Let's pull up an image so you can see what I'm talking about. From figure 8.47, we can clearly see that an aneurysm originating from this region here could compress the optic chiasm, resulting in bitemporal hemianopia. If you're unfamiliar with bitemporal hemianopia, I recommend watching the section on ophthalmology. Of all the aneurysms to be familiar with for step 1, I think the posterior communicating artery, or PCOM, is the most important. This is because an aneurysm originating from the PCOM can compress the oculomotor nerve, or cranial nerve 3. It's important to know that the oculomotor nerve sends parasympathetic information to the eye through the superficial axonal fibers and somatic information to the eye through deep axonal fibers. So superficial fibers contain parasympathetic information, whereas deep axonal fibers contain somatic information. This means the size of the aneurysm and degree to which it compresses the oculomotor nerve determines the patient's symptoms. Compression of the superficial parasympathetic fibers of cranial nerve 3 results in mydriasis and ptosis, and compression of the deep somatic fibers of cranial nerve 3 can result in paralysis of the corresponding ocular muscles. From figure 8.47, we can clearly see the posterior communicating artery right here. Recall that the oculomotor nerve passes between the superior cerebellar artery and posterior cerebral artery as it projects anterior like this. This means that an aneurysm originating from the PCOM right here could compress the oculomotor nerve, resulting in the symptoms we just discussed. Welcome to the second part of section 9. In this video, I'll focus on examples associated with the neurovasculature, which should be helpful in applying and integrating the material. Let's get started. Okay, the first question. A 68-year-old right-handed woman presents with right-sided facial paralysis, sparing the forehead, and paralysis of the right upper limb. Rupture of an aneurysm likely occurred near what vessel? Okay, from the question, we know that the patient has right-sided facial paralysis, sparing the forehead, and paralysis of the right upper limb. These symptoms should immediately make you think of the homunculus and its vascular supply. Let's pull up the homunculus so you can more clearly see what's happening. This is figure 8.6, which shows the homunculus. From this image, we can see that our patient has damaged this region of the homunculus because we know that the patient is experiencing paralysis of the upper extremity and the face. Recall that the lateral portion of the precentral gyrus is supplied by the middle cerebral artery, or MCA. The question asks about rupture of an aneurysm, so with this information, we can deduce that an aneurysm originating from the MCA must have ruptured. Because this patient has right-sided paralysis, and we know that the corticospinal tract decussates, we can deduce that the left MCA must be affected. Also note from the question stem that the patient had facial paralysis, but that the forehead was spared. This is because a lesion to the cortex would cause paralysis of the inferior aspect of the face, whereas a lesion to the facial nucleus in the pons would cause complete paralysis of the face. We cover this in more detail in section 3, so go review that if you're confused. This is table 8.5, which provides a list of clinically relevant aneurysms and the associated lesion area and symptoms. From this table, we can see that rupture of an aneurysm in the MCA results in a stroke of the MCA distribution, resulting in identical symptoms to that of an MCA stroke, which is contralateral paralysis and sensory deficits of the face and upper limb. Okay, let's do another question. A 65-year-old right-handed male with a history of diabetes and a previous myocardial infarction presents with sudden loss of vision. Fundoscopy shows a cholesterol embolus. From what major branch of the circle of Willis did the embolus most likely originate? Okay, from the question stem, we know that the patient has vision loss, and fundoscopy shows a cholesterol embolus. We also know that the embolus came from the circle of Willis. Recall that the ophthalmic artery is a branch of the internal carotid artery, so the embolus must have originated from the internal carotid artery. Let's pull up an image so you can see what's going on. This is figure 8.46, which provides a general overview of the neurovascular anatomy. From this image, we can see the ophthalmic artery right here. Notice how this artery is a direct branch of the internal carotid artery, this region right here. So again, the embolus most likely originated from the internal carotid artery. Okay, here's another question. An 80-year-old right-handed male presents with paralysis of the right lower extremity. What vessel shown below is most likely occluded? In order to get this question right, you need to be familiar with the circle of Willis and the vascular supply of the precentral gyrus. Recall that the anterior cerebral artery, or ACA, supplies blood to the lower extremities. Because our patient has paralysis of the right lower extremity, or right leg, we can deduce that the left ACA must be occluded. From this figure, the left ACA is right here. From figure 8.6 of the homunculus, we can clearly see that our patient has damaged this region. This is because we know that the patient is experiencing paralysis of the lower extremity. Again, the medial portion of the precentral gyrus is supplied by the anterior cerebral artery, or ACA. Because this patient has right-sided paralysis, and we know that the corticospinal tract decussates, we can deduce that the left ACA must be affected. So again, the left ACA must be occluded, which is right here. From table 8.4, we can see that an occlusion of the anterior cerebral artery results in damage to the medial aspect of the primary sensory and motor cortices. This results in contralateral motor and sensory deficits of the leg. Okay, next question. A 67-year-old right-handed male presents with a blood pressure of 210/170 and left-sided paralysis and sensory loss. Imaging shows hyperintensities near the striatum. What vessel is most likely damaged? Okay, so hypertension and damage to the striatum should immediately make you think of the lenticulostriate arteries. Recall that chronic hypertension is highly associated with Charcot-Bouchard microaneurysms of the lenticulostriate arteries. So again, because this patient has an extremely high blood pressure, and we know that there are hyperintensities near the striatum, we can deduce that this patient most likely has damaged the lenticulostriate arteries. From figure 8.49, we can see that damage to the lenticulostriate arteries would result in ischemia to the internal capsule and basal ganglia. If the internal capsule becomes damaged, we'd expect the patient to develop contralateral paralysis and sensory deficits. This is because the corticospinal, corticobulbar, and corticothalamic tracts pass through the internal capsule and then decussate. From the question stem, we know that the patient presented with left-sided paralysis and sensory loss. Again, because the tracts decussate, we'd expect the right internal capsule to be damaged. So in this case, we can deduce that the right lenticulostriate arteries must be damaged. If the basal ganglia becomes damaged, we'd expect the patient to develop movement abnormalities, but this would be hard to predict unless more information was given about what part of the basal ganglia was damaged. From table 8.4, we can see that damage to the lenticulostriate arteries would result in contralateral paralysis and sensory deficits of the entire body. And again, the basal ganglia would also likely be damaged, which would result in movement abnormalities, but those would be hard to predict. Okay, let's do another question. A 77-year-old right-handed male presents with left-sided hemiparesis, loss of vibration and proprioception on the left side, and right-sided tongue deviation. What vessel is likely occluded? One of the most prominent clues of this question is right-sided tongue deviation. We've only learned about one vessel that, when occluded, can result in damage to the hypoglossal nucleus, which can cause tongue deviation. Recall that the anterior spinal artery, or ASA, supplies blood to this region, which explains the patient's deviated tongue. Remember from section 3 on cranial nerves that damage to the hypoglossal nucleus results in tongue deviation to the ipsilateral side, so we can deduce that the right ASA must be occluded. Let's pull up some images to review the patient's symptoms. On this slide, we have figure 8.20, showing a transverse section of the medulla. Recall from part 1 of this section that the paramedian branches of the ASA supply blood to approximately this region right here. As we can see, the hypoglossal nucleus is right here, and because this nucleus is so medial and deep, it can become ischemic during an occlusion of the ASA or the paramedian branches of the ASA. Also notice how the medial lemniscus and the corticospinal tracts are both medial and receive blood directly from the paramedian branches of the ASA, so these are also affected. From figure 8.13, we can see that the dorsal columns ascend through the medial lemniscus and are responsible for vibration and proprioception. So damage to the medial lemniscus, right here, in an ASA stroke would result in contralateral loss of vibration and proprioception. In this case, we know that the right medial lemniscus was damaged, which explains the patient's loss of vibration and proprioception on the left side of the body. From figure 8.15, we can see that the corticospinal tract descends through the anterior pyramids, so damage to the anterior medulla in an ASA stroke would result in contralateral paralysis. In this case, we know that the right pyramid became ischemic, which explains why the patient has left-sided paralysis. Okay, let's do another question. A 67-year-old right-handed male with a history of diabetes mellitus and multiple myocardial infarctions presents with a 2-week history of progressive bilateral upper and lower limb paralysis and bilateral loss of pain and temperature. Proprioception and vibration are intact bilaterally. What vascular territory is likely ischemic? Okay, hopefully from the question stem you gathered that this patient has a history of atherosclerosis. We also know some part of the corticospinal tract is disrupted because this patient has bilateral paralysis. Likewise, we know that some part of the spinothalamic tract is disrupted because the patient has bilateral loss of pain and temperature. Perhaps most importantly, we know that the dorsal columns are unaffected because the question stem states that proprioception and vibration are intact bilaterally. Hopefully all this information has made you think of ischemia to the vascular territory supplied by the anterior spinal artery, or ASA ischemia. Let's pull up an image so you can more clearly see what's going on here. This is figure 8.9, which shows a cross-section of the spinal cord. Again, this is anterior and this is posterior. Recall that after the ASA descends past the medulla, it supplies blood to approximately this region here. Notice how this vascular territory supplies the anterior and lateral aspects of the spinal cord, but spares the dorsal columns. Widespread atherosclerosis can result in ischemia to the ASA and the anastomosing branches that feed the ASA, resulting in ischemia to the area I've outlined here. In this case, the blood supply is compromised, resulting in damage to the corticospinal tracts, which explains the bilateral paralysis, the spinothalamic tracts, which explains the bilateral loss of pain and temperature, and as we can see, the dorsal columns are spared, which explains why proprioception and vibration are intact bilaterally. So again, the vascular territory supplied by the ASA is ischemic due to widespread atherosclerosis. Okay, let's do another question. A 52-year-old right-handed male with a history of coronary artery disease presents with vertigo, ataxia, dysphagia, and difficulty speaking. What vessel is most likely occluded? Recall from part 1 of this section that dysphagia and dysphonia, or difficulty speaking, are unique to lateral medullary syndrome. Lateral medullary syndrome is caused by damage to the posterior inferior cerebellar artery, or pica. Let's pull up some figures to make this clearer. From figure 8.46, we can see that the pica is right here. Again, notice how the pica wraps around the lateral aspect of the medulla, hence the name lateral medullary syndrome. It's important to know that lateral medullary syndrome can also be caused by damage to the vertebral artery. This is because the pica is a direct branch of the vertebral artery, which we can clearly see from this image. So on the last slide, I said the answer was damage to the pica, but if you thought of the vertebral artery, you'd also be correct. From figure 8.20, which shows a transverse section of the medulla, we can more clearly identify the structures that would be damaged in lateral medullary syndrome. Again, this is anterior and this is posterior. And the pica supplies blood to the lateral medulla, or approximately this region here. Recall from part 1 of this section that it's most important to remember that the nucleus ambiguus is damaged in this syndrome. Recall that the nucleus ambiguus contains motor information from cranial nerves 9 and 10. From section 3, recall that cranial nerves 9 and 10 provide motor output to the pharynx and larynx, so damage to these structures would result in dysphagia and dysphonia. Also notice that the vestibular nuclei are right here, so damage to these nuclei explains the patient's vertigo. The patient also has ataxia, which can be explained by damage to the inferior cerebellar peduncle right here. From table 8.4 and this image, the patient also could have presented with a number of other symptoms. However, in order to have gotten this question correct, you needed to recall that dysphagia and dysphonia are unique to lateral medullary syndrome. Again, this is due to damage to the nucleus ambiguus. From table 8.4, we can see that damage to the posterior inferior cerebellar artery or the vertebral artery can both result in lateral medullary syndrome. On the right, we have a list of structures that are compromised and the corresponding symptoms. Okay, let's do another question. A patient presents with Horner syndrome, nystagmus, right-sided facial paralysis, and taste deficits. What vessel is most likely occluded? Recall from part 1 of this section that facial paralysis and taste deficits are unique to lateral pontine syndrome. Lateral pontine syndrome is caused by damage to the anterior inferior cerebellar artery, or AICA. Let's pull up some figures to make this clear. From figure 8.46, we can see that the AICA is right here. Again, notice how the AICA wraps around the lateral aspect of the pons, hence the name lateral pontine syndrome. From figure 8.18, which shows a transverse section of the pons, we can more clearly identify the structures that would be damaged in lateral pontine syndrome. Again, this is anterior and this is posterior. The AICA supplies blood to the lateral pons, or approximately this region here. For this syndrome, it's most important to remember that the facial nucleus and the solitary nucleus are damaged. Damage to the motor aspect of the facial nucleus will result in total ipsilateral facial paralysis. Recall that the solitary nucleus contains sensory information from cranial nerves 7, 9, and 10. So knocking out the sensory aspect of the facial nerve would result in taste deficits from the ipsilateral anterior 2/3 of the tongue. On the other hand, knocking out sensory aspects of cranial nerves 9 and 10 would result in more vague symptoms, which we explained in part 1 of this section. So again, facial paralysis and taste deficits from the anterior 2/3 of the tongue are symptoms unique to lateral pontine syndrome. Also notice that the vestibular nuclei are right here. So damage to these nuclei explains the patient's nystagmus. The patient also has Horner syndrome, which can be explained by damage to the descending sympathetic fibers from the hypothalamospinal tract in the lateral tegmentum, which is about right here. From table 8.4 and this image, the patient also could have presented with a number of other symptoms. However, in order to have gotten this question correct, you needed to recall that facial paralysis and taste deficits are unique to lateral pontine syndrome. Again, this is due to damage to the facial nucleus and the solitary nucleus. From table 8.4, we can see that damage to the anterior inferior cerebellar artery results in lateral pontine syndrome. On the right, we have a list of structures that are compromised and the corresponding symptoms. Okay, let's do another question. An 88-year-old right-handed female presents with quadriplegia and bilateral facial paralysis. An astute medical student notices that the patient has the ability to respond by blinking. What vessel is most likely occluded? Recall from part 1 of this section that complete paralysis and facial paralysis with the ability to blink is unique to locked-in syndrome. Also recall that locked-in syndrome is caused by damage to the basilar artery. Let's pull up some figures to make this clear. From figure 8.46, we can see that the basilar artery is right here. Again, notice how the basilar artery is a midline vessel that supplies blood to the medulla, pons, and the midbrain. Because so much of the anatomy is affected in this type of lesion, I find it most helpful to focus on the structures that are spared. In order to see this, let's focus on the midbrain. This is figure 8.16, which is a cross-section of the midbrain. This is anterior, and this is posterior. From the last image, we know that the basilar artery is about right here. The branches of the basilar artery dive deep into the brainstem, so much of the anatomy in the midbrain is damaged. However, the oculomotor nerve right here is one of the deeper structures of the midbrain and is typically not damaged during occlusion of the basilar artery. This is why patients can blink and move their eyes vertically. The reticular formation and the tegmentum are also spared, which explains why the patient has preserved consciousness. Recall from part 1 of the section that the reticular formation is a group of many nuclei throughout the brainstem, so it can't be easily identified on one image like this. The tegmentum is also a general area within the brainstem, but on this section of the midbrain, it's located throughout this region about right here. Again, preservation of the reticular formation and the tegmentum explains why the patient has preserved consciousness. From table 8.4, we can see that damage to the basilar artery results in locked-in syndrome. On the right, we have a list of structures that are compromised and the corresponding symptoms. But again, I find it most helpful to recall those structures that are not damaged, which is shown right here. Okay, let's do another question. A 26-year-old right-handed male presents with abnormalities of the right eye, including mydriasis, ptosis, and difficulty adducting the eye. An aneurysm from what vessel is most likely responsible for the patient's symptoms? Recall from part 1 of this section that mydriasis, ptosis, and difficulty adducting the eye are unique symptoms associated with damage to the oculomotor nerve, or cranial nerve 3. Remember, an aneurysm originating from the posterior communicating artery, or PCOM, can compress the oculomotor nerve, resulting in the symptoms described in this vignette. Let's pull up some figures to make this clear. From figure 8.47, we can see the posterior communicating artery right here. Recall that the oculomotor nerve passes between the superior cerebellar artery and the posterior cerebral artery as it projects anteriorly like this. This means that an aneurysm originating from the PCOM right here could compress the oculomotor nerve, resulting in the symptoms described in this vignette. From table 8.5, notice that an aneurysm originating from the PCOM can compress the superficial parasympathetic fibers of cranial nerve 3, resulting in mydriasis and ptosis, and compression of the deep somatic fibers of cranial nerve 3 can result in paralysis of the corresponding ocular muscles.
Welcome to section 10 of neurology. In this section, I'll be discussing the ventricular system. Let's get started. This is figure 8.50, which provides an overview of the ventricular system. For step 1, you need to know that all of the ventricles are lined with special cells that produce cerebrospinal fluid, or CSF. When there are a group of cells that do this, it's referred to as the choroid plexus. Notice the arrows from this figure which map out the flow of CSF. From the lateral ventricles, CSF moves through the interventricular foramina of Monro into the third ventricle. Notice the interventricular foramina of Monro right here. Once in the third ventricle, CSF moves into the fourth ventricle through the cerebral aqueduct, which can be seen right here. At this point, the CSF moves into the subarachnoid space through the foramen of Magendie and the two lateral foramina of Luschka. Okay, with this in mind, let's look at a mid-sagittal view of the brain to see where the CSF goes after moving into the subarachnoid space. This is figure 8.51, which provides an overview of the normal flow of CSF. From the last slide, we showed that the CSF had just moved into the subarachnoid space through the foramen of Magendie and the two lateral foramina of Luschka. After passing into the subarachnoid space, the CSF enters the venous system through the arachnoid granulations, and these drain into the superior sagittal sinus. Okay, before we move on, I'd like to briefly mention that the area postrema is located near the floor of the fourth ventricle in the medulla. So the fourth ventricle is right here, so the area postrema is at the floor of the fourth ventricle, about right there. This area is an important region in the brain responsible for inducing vomiting. If the ventricular system is obstructed, excess CSF will accumulate, which can cause several pathologies. Another name for excess CSF is hydrocephalus. For step 1, you need to be familiar with 3 types of hydrocephalus. This includes communicating hydrocephalus, non-communicating hydrocephalus, which is also known as obstructive hydrocephalus, and hydrocephalus ex vacuo. Communicating hydrocephalus is pretty straightforward. Communicating refers to the idea that the ventricular system isn't directly obstructed. Rather, the arachnoid granulations are obstructed. In this sense, the ventricles are able to communicate with one another, hence the name communicating hydrocephalus. This type of an obstruction results in dilated ventricles and increased intracranial pressure. So increased pressure. Non-communicating hydrocephalus refers to the idea that there is an obstruction within the ventricular system. In other words, the ventricles are not communicating with each other, hence the name non-communicating hydrocephalus. This type of an obstruction also results in dilated ventricles and increased intracranial pressure.
so increased pressure. Finally, hydrocephalus ex vacu refers to the idea that the ventricular system is enlarged due to decreased brain tissue rather than an increase in CSF. This could occur, for example, in a patient with dementia, which results in cerebral atrophy. In this case, the intracranial pressure would be normal because there is no obstruction within the ventricular system, so normal pressure. Okay, with this in mind, let's briefly review the dural venous sinuses. This is figure 8.52 from your text, which clearly shows the meninges. Recall that the meninges are the three membranes that surround the brain and spinal cord. From superficial to deep, these include the dura mater, the arachnoid mater, and the pia mater. Notice from this image that the dural venous sinus is right here. This is formed by spaces within the dura mater. Dural venous sinuses are important because they receive the arterial blood and cerebrospinal fluid and allow the brain to remove its waste products from the cerebral circulation. Okay, with this in mind, let's look at figure 8.53. This is figure 8.53 from your text, which shows a lateral view of the dural venous sinuses. I'm not going to read each of the sinuses to you, but take a moment to become familiar with this image. For step one, it's most important to be familiar with the superior sagittal sinus and the cavernous sinus. The superior sagittal sinus is important because it receives CSF from the arachnoid granulations. The cavernous sinus is important because it contains cranial nerves 3, 4, parts of 5, 6, and the internal carotid artery, which we've talked about in previous lectures. Notice how several sinuses, as well as the ophthalmic veins, drain into the cavernous sinus. This is clinically important because infections of the eye can spread to the ophthalmic veins, which can travel to the cavernous sinus and spread throughout the brain. This is figure 8.24, which shows a coronal view of the cavernous sinus. Again, notice that cranial nerves 3, 4, parts of 5, and 6 all traverse the cavernous sinus. We can also see the internal carotid artery right here. Okay, with this in mind, let's do a few questions. A 2-week-old boy presents with bulging fontanelles and papilledema. His history is significant for bacterial meningitis, which was promptly treated and appeared to have resolved several days ago. What is the likely cause of the patient's symptoms today? From the question stem, we know that the patient has bulging fontanelles and papilledema. These are both signs that there is increased intracranial pressure. We also know that the patient had meningitis that has since resolved. For step one, it's important to know that meningitis can cause scarring of the arachnoid granulations, which disrupts their ability to absorb CSF. The reduced ability to absorb CSF results in an accumulation of CSF in the ventricular system, which results in increased intracranial pressure. So again, the decreased CSF absorption results in increased CSF in the ventricles, which results in increased pressure, which results in papilledema and bulging fontanelles. Recall that when the arachnoid granulations are obstructed, resulting in excess CSF, we call it communicating hydrocephalus. From figure 8.51, we can see that obstruction of the arachnoid granulations would prevent the proper circulation of CSF, resulting in communicating hydrocephalus. Okay, let's do another question. An MRI of the brain shows enlarged lateral ventricles and an enlarged third ventricle, but a normal-sized fourth ventricle. What structure is obstructed, resulting in the MRI findings? From the question stem, we know that the patient has enlarged lateral ventricles and an enlarged third ventricle, but a normal-sized fourth ventricle. Hopefully from this description, you were able to deduce that there is an obstruction between the third and fourth ventricles. Let's pull up an image so you can see what's going on. From figure 8.50, we can see that the cerebral aqueduct drains CSF from the third ventricle into the fourth ventricle. Because our patient has a normal-sized fourth ventricle and a dilated third ventricle, we can deduce that the cerebral aqueduct must be obstructed. Recall that a structural block within the ventricular system is called a non-communicating hydrocephalus. So our patient has a non-communicating hydrocephalus due to obstruction of the cerebral aqueduct. Okay, before we move on, I'd like to mention that it's incredibly high yield to know that the pineal gland sits directly posterior to the cerebral aqueduct, and this is a common cause of this type of obstruction. This could occur, for example, in patients with pineal gland tumors. So remember, the pineal gland can cause an obstruction of the cerebral aqueduct because it sits just posterior to the cerebral aqueduct right here. Okay, let's do another question. A 67-year-old female with Alzheimer's disease received a routine MRI, and the radiology technician noticed the patient had extremely large ventricles. What is the most likely cause? Okay, pretty straightforward. Hopefully you notice that the patient has Alzheimer's disease, which should immediately make you think of cerebral atrophy. The decreased brain tissue rather than an increase in CSF is what causes the ventricles to appear dilated on imaging. Recall that this type of hydrocephalus is called hydrocephalus ex vacu. So again, hydrocephalus ex vacu is due to decreased brain tissue rather than an increase in CSF. Okay, let's do one more question. A 2-year-old boy has an infection of the eye. The physician is concerned that the infection may rapidly spread to the cavernous sinus. Through what structure would this be possible? From the question stem, we know that the infection may spread into the cavernous sinus, and we're asked through what structure this would be possible. Recall that the ophthalmic vein drains directly into the cavernous sinus. So again, infections of the eye can spread to the cavernous sinus through the ophthalmic vein. The physician is concerned about spread to the cavernous sinus because then the infection could spread throughout the brain and become much more life-threatening. From figure 8.53, we can see that the ophthalmic vein receives blood from the eye and drains directly into the cavernous sinus.
Welcome to section 11 of neurology. In this section, I will be discussing aphasia. Let's get started. For step one, you need to be familiar with several types of aphasia. It's most important to understand Broca's aphasia, Wernicke's aphasia, and conduction aphasia. Let's discuss Broca aphasia first. Broca's area is located in the inferior frontal gyrus, which we'll look at in a moment. If this region of the brain is damaged, then patients will present with several key findings. First, their ability to comprehend verbal and written language is intact. Second, they have difficulty repeating phrases, so difficulty with repetition. And third, they are unable to speak fluidly. Fluidity refers to the ability to speak in a melodic and convincing manner. Hopefully after we go through some questions later in this lecture, you'll be more comfortable with fluidity. Because patients are able to comprehend verbal and written language, they recognize their difficulty with language and become frustrated. So these patients are often frustrated due to the awareness of their cognitive deficit. Some students use the letter B in Broca to remind them the boca, which just means mouth in Spanish, is broken. So B for broken boca. In other words, their mouth, in a sense, is broken, so they can't get words out. And this inability to speak is a unique finding to Broca aphasia. This is figure 8.2, which is a lateral view of the brain. This is posterior, and this is anterior. As we briefly discussed in section 1 of this chapter, Broca's area is right here. Again, this is in the inferior frontal gyrus. Okay, the next topic is Wernicke aphasia. Wernicke's area is located in the superior temporal gyrus, which we'll look at in a moment. If this region of the brain is damaged, then patients will present with several key findings. First, their ability to comprehend verbal or written language is impaired. Second, they have difficulty repeating phrases. And third, their speech is meaningless, but the patient can articulate in a melodic and convincing manner. Again, this idea refers to fluidity, and in this case, fluidity is intact. Because these patients are unable to comprehend verbal and written language, they don't recognize their difficulty with language, so they're not aware of their cognitive deficit. Some students use the letter W in Wernicke to remind them of the phrase word salad. In other words, patients with Wernicke aphasia are able to speak, but it's just gibberish nonsense. So in that sense, it's word salad. This is figure 8.2, which again is a lateral view of the brain. And as we discussed in section 1 of this chapter, Wernicke's area is right here. And recall that this is the superior temporal gyrus. Okay, before we move on to conduction aphasia, I'd like to mention that both Broca's area and Wernicke's area are supplied by the middle cerebral artery, or MCA. Recall from section 9 that the vascular territory of the MCA is approximately here. It's important to know that a stroke of the terminal branches of the MCA could result in isolated damage to Broca's area or Wernicke's area, depending on the region of the vessel that's occluded. So again, the MCA supplies blood to both Broca's area and Wernicke's area. Okay, the last type of aphasia is called conduction aphasia. Conduction aphasia occurs due to damage to the arcuate fasciculus. The arcuate fasciculus is a fibrous band between Broca's area and Wernicke's area that relays important information about language. If this region of the brain is damaged, then patients will present with several key findings. First, their ability to comprehend verbal and written language is intact. Second, they have difficulty repeating phrases, so difficulty with repetition. And third, they are able to speak fluidly, so fluidity is intact. This is figure 8.2, which is a lateral view of the brain. And as we can see from this image, Broca's area is right here, and Wernicke's area is right here. Again, the arcuate fasciculus is a fibrous band between Broca's area and Wernicke's area, so we expect it to be right here. This is table 8.6, which provides the important information about each type of aphasia. I'm not going to read the table to you, but it is a good summary of what we've just covered. A 67-year-old female with a history of a stroke presents to a neurologist for follow-up care. As the history is taken, the neurologist notices the woman has difficulty with repetition despite normal comprehension and fluidity. What area of the brain is likely lesioned? Notice from the question stem that the patient can speak and understand normally, but the ability to repeat is impaired, as you can see, because she has difficulty with repetition. This type of presentation is unique to conduction aphasia. Again, conduction aphasia is caused by damage to the arcuate fasciculus. So we're asked what area of the brain is likely lesioned. This would be the arcuate fasciculus. From table 8.6, we can see that conduction aphasia results in impaired repetition with intact comprehension and fluidity. Okay, let's do another question. A 72-year-old male is brought to the emergency department by his concerned children. Since admission, the man appears to have asked well-articulated questions, but they lack meaning. Upon further exam, he has difficulty repeating phrases and does not appear to understand the questions being asked. What region of the brain shown below is likely damaged? Okay, hopefully from the question stem you noticed that the patient is asking well-articulated questions, but they lack meaning. This refers to fluidity. Remember, this type of fluidity that lacks meaning is specific for Wernicke aphasia. In order to get this question right, you need to know that Wernicke's area is located right here. Again, this is the superior temporal gyrus. From table 8.6, we can see that Wernicke aphasia results in impaired comprehension and impaired repetition with intact fluidity. Okay, let's do one more question. An 88-year-old female is brought to the emergency department due to difficulty speaking. When asked to make a fist, she does so. When asked to repeat a simple phrase, she becomes highly agitated and shrugs her shoulders in frustration. What area of the brain shown below is likely damaged?
Okay, so from the question stem, we know that the patient can comprehend language because she was able to follow instructions and make a fist. We also know that the patient can't speak very well or repeat phrases because she became highly agitated and shrugged her shoulders when asked to repeat a simple phrase. Hopefully this presentation made you think of Broca aphasia. In order to get this question right, you need to know that Broca's area is located right here. Again, this is the inferior frontal gyrus. From table 8.6, we can see that Broca aphasia results in impaired repetition, impaired fluidity, and intact comprehension. And that concludes this section.
Welcome to section 12 in neurology. In this section, we will be talking about dermatomes, myotomes, and their associated clinical reflexes. So let's get started. So first, let's talk about dermatomes. Now, dermatomes are areas of skin associated with a single spinal nerve. So pain in a certain region can implicate a certain spinal cord level. And recall that dermatome sensation includes pain and temperature. And as you recall from section 2, the spinothalamic tract is responsible for pain and temperature. Dermatome sensation also includes proprioception and vibration, which is carried through the dorsal columns. Now here's figure 8.54 from your text showing the dermatomes. So while you can memorize each level, I would recommend just memorizing the dermatomes that are on the next table, which I'll show you on the following slide. And I'll go over these here. For example, know that C2 is the upper half of the scalp, and that C3 is the upper neck. You can see that on both sides. And then C6 is the thumb, and C7 includes this middle finger. And on this particular map, we see that it includes the index finger as well. Just understand that on different dermatome maps that you'll see, there's going to be slight variation. So what's most important is to recognize that the C7 dermatome includes that third digit, and then C8 includes the fifth digit, or the little finger. And then now for the thoracic dermatomes, here in dark blue, memorize that T4 is at the nipple line, and that T7 is at the xiphoid process, and T10 is the level of the navel. So now let's move to the lumbar dermatomes in red. So know that L1 is along the inguinal line here, and that L4 is at the level of the patella and the medial malleolus. So it travels down like this. And know that L5 is the dorsum of the foot. So now moving on to the sacral dermatomes, know that S1 includes the lateral malleolus, which is best seen on this right image. And also know that S2, 3, and 4 all cover the perineum. Here is table 8.7 showing a list of the important dermatomes for step 1. We just went through these on the previous slide showing figure 8.53. I won't read these to you here, but you may pause the video if you want to take this in. So now let's do a question. Let's say a patient is hospitalized following a car crash. He complains of pain on the surface of the abdomen about 2 inches superior to the inguinal ligament. If a vertebral fracture is the cause of the pain, what vertebral level is likely damaged? The cervical, thoracic, lumbar, or sacral? Okay, so the question stem states that there's loss of sensation above the line of the inguinal ligament. And we suspect a vertebral fracture is compressing a spinal nerve associated with a dermatome above this region. So which of the 4 vertebral regions are we concerned about? Well, we know that the L1 dermatome is at the inguinal line, and that the T10 dermatome is at the navel line. And the question stem states that the pain is above the inguinal ligament line. So we are not thinking it's lumbar, which is L1 and lower. Instead, we suspect the thoracic level. We could specifically say that it's probably between the T11 or T12 dermatomes, because we know that it's below the belly button and above L1. Step 1 will not ask you to know the exact vertebral level based solely on dermatomes, except for the ones that we specifically stated in table 8.7. So being able to identify or localize within a few vertebral levels, like between T11 and T12, is quite sufficient for step 1. So let's do another example. Let's say a patient is hit in the neck with a baseball bat. Radiograph shows spinal cord damage to the region beneath the C6 vertebra on the left side. If this trauma has altered sensation on the left side, where would it likely manifest? So this question is almost the reverse of the last question. Here the stem is saying that there is suspected damage to the spinal nerve below C6. What spinal nerve would this be? Well, recall from section 2 that spinal nerves in the cervical region exit above their respective vertebrae. So the C6 spinal nerve would exit above the C6 vertebrae. So what would exit below C6? Well, that would be the C7 spinal nerve. So with damage to the C7 spinal nerve, what dermatome is likely to lose sensation? Well, recall that the middle finger, or third digit, is part of the C7 dermatome. So we would expect that there would be diminished or altered sensation along the C7 dermatome, which includes the third digit. And here we've said that there's damage to the C7 spinal nerve, but they are having altered sensation, not necessarily absent sensation. And absent sensation can occur if there's complete severing of the spinal nerve, meaning no sensation can get back in. And we will touch on this in a moment. So now let's talk about referred pain. Referred pain is sensation from an internal organ that enters the spinal cord at a given spinal cord level. Then the pain is actually felt in the dermatome associated with that spinal cord level. Some classic examples are pancreatitis. So the pancreas causes diaphragm irritation, and the diaphragm is innervated by C3, 4, and 5. And so the sensation is sent to those spinal nerves, but the central nervous system identifies pain at that spinal cord level, but in the dermatomal region. Another example is appendicitis, where sensation is sent to the T10 spinal nerves, but the pain is felt at the T10 dermatome. So it's as though the spinal cord senses the pain from the correct level, but attributes it to the wrong part. So we're having pain in the dermatome when there's no problem with the dermatome, rather there was a problem with the internal organ. So let's draw this out. So here's a cross-section of the thoracic spinal cord. So sensation from an internal organ, it will enter at the spinal cord through the dorsal root. Of course, that will be the dorsal root ganglion, but the pain is actually manifest as though the sensation was coming from the dermatomal region. So if we say that this internal organ is the appendix, then the dermatomal region will be T10, or the navel region. So there's a problem with the internal organ, but they feel the pain in the dermatome. So now let's talk about radiculopathy. Radiculopathy is pain resulting from a compression or pinching of a spinal nerve. Now, radiculopathy was actually an example that we discussed before. The patient gets in a car crash and they complain of pain, or they get hit in the neck with a baseball bat and they experience altered sensation. So that's radiculopathy. And this can cause paresthesias, or tingling sensation, which we could say is altered sensation. But there can also just be pain. So just think of radiculopathy as compression or pinching of a spinal nerve. So contrast radiculopathy to referred pain. Both cause pain, but one is caused by compression of the spinal nerve, while the other is caused by another seemingly unrelated organ. But both can cause pain in that dermatome. Now, if we're talking about complete severing of the spinal nerve, this would prevent sensation from ever reaching the spinal cord. So severing the posterior root of the T10 spinal nerve would cause the patient to feel no pain. They would be numb at that region, instead of just feeling pain if it were simply compressed or pinched. Now, myotomes are muscle groups associated with a single spinal nerve, and diminished strength in a certain region of the body can implicate a certain spinal cord region. For example, the C6 myotome is responsible for bicipital flexion. And with damage to the C6 spinal nerve, this patient would have decreased bicipital flexion. So clinically, one can test the strength of a given myotome or spinal nerve by testing its associated function. So here's table 8.8 showing the myotomes. These are the ones that are clinically relevant and important for step 1. I won't read them to you here, but you may pause the video to take this in. Now let's go ahead and apply this knowledge with some examples. A patient has a known herniated vertebral disc and presents with pain in his lower extremity, including the medial ankle. During a neurologic exam, where would the diminished strength be noticed? So basically, the patient has radiculopathy, resulting in pain of the medial malleolus. What spinal cord level are we dealing with here? Well, the medial malleolus is part of the L4 dermatome. If the herniated vertebral disc were to result in decreased strength, we would expect the strength to be decreased at the L4 myotome. So how would you test this clinically? Well, you would test the strength of the patient being able to extend the knee. In other words, with decreased strength at the L4 myotome, we would expect that there would be decreased strength in knee extension. So here again is table 8.7, where you can see that the L4 dermatome is responsible for the patella and the medial malleolus. The medial malleolus is where the patient identified the pain. Now looking again at table 8.8, showing the myotomes, we can see that the L4 myotome is responsible for knee extension. Now let's talk about clinical reflexes. Absent clinical reflexes can implicate a specific spinal cord level. So here's table 8.9, showing the list of clinical reflexes you need to be familiar with. I won't read them to you here, but you may pause the video to take this in. Now let's do a question to apply this. A patient demonstrates hyporeflexia when the triceps tendon is hit with a reflex hammer. The patient also complains of occasional shock-like pain in the hand. Radiograph shows herniation within the cervical spinal cord. Now, what region of the hand is likely experiencing pain? So this patient has hyporeflexia at the C7 spinal cord level, which is the level responsible for the triceps reflex. Now, the hand pain is described as a paresthesia, that occasional shock-like pain. We also know that the patient has a cervical disc herniation, making us think that the paresthesia is likely caused by a radiculopathy. Now, everything points to radiculopathy of the C7 spinal nerve because of the hyporeflexia of the triceps tendon, which is the C7 myotome. So if we are identifying the C7 spinal cord level as being the one that is damaged, then pain we would expect to be along the C7 dermatome. Here again is table 8.7, which you can see the C7 dermatome includes the third digit or the middle finger. And since the patient said that they are having pain in the hand, we would expect that that pain should at least include the middle finger or third digit. Now here again is table 8.9 showing the clinical reflexes. And we can see that the C7 region is responsible for the triceps reflex. Now the clinical reflexes are closely associated with the myotomes. So where we thought of elbow extension as being associated with the C7 myotome, we can see that the same region, C7-C8, is responsible for the triceps reflex, which is ultimately extension of the elbow. Now let's do another question. Let's say the anterior root of the L4 spinal nerve is damaged. What reflex would be altered? So let's draw the anterior root. This is the L4 spinal nerve. And if this anterior root was damaged, we would expect an alteration in the patellar reflex, because the patellar reflex requires the L4 spinal nerve to be intact. If we were to extend the question, we could ask whether the patient would demonstrate hyperreflexia or hyporeflexia. Well, since the spinal nerve is the lower motor neuron, we would expect lower motor neuron signs, which includes hyporeflexia, not hyperreflexia. This section is not meant to be an upper and motor neuron lesion discussion, so please refer to section 2 of this chapter for more information on that. So in review, you need to think of the dermatomes, myotomes, and clinical reflexes all as one. And also recall that spinal nerve damage causes lower motor neuron signs. So if you're able to recall that spinal nerve damage causes lower motor neuron signs, and if you're given a question about a certain spinal cord level, and you can answer anything about the associated clinical reflexes, myotomes, or dermatomes, or you could do everything backwards, you find the dermatome and identify what spinal cord level is responsible for that dermatome, then you can find the associated clinical reflexes that may be altered. If you're able to do that, then you'll do quite well with any of this information regarding dermatomes, myotomes, and reflexes on step 1.